raise this mic up just a bit. I want to personally welcome each and every one of you to what I call the Humanitarian Mall east of the Anacostia River. My name is Rasan Bernard. I am the president of Building Bridges Across the River. You are here at THEARC, the acronym Town Hall Education, Arts, and Recreation Campus. We have a lot to celebrate. We just cut our ribbon in February on this new building. You are in the newest edition, phase 3 of THEARC, so it's now completed. We are now at 203,000 square feet, the largest social service, multi-sector, nonprofit collaboration in the country. And so, you're in a good place today. Building Bridges Across the River has been building bridges since 1997. And obviously, in 2005, we built this wonderful place called THEARC. But we've been building bridges beyond that. So our arts and culture bridges, you are now in the Black Box Theater. We have a main theater. It's the largest theater footprint east of the Anacostia River. When kids want to watch movies in the summer, instead of going to Chinatown, which is their closest theater, they come to THEARC. We are building food access bridges. We have a farm and Bridge Park plots that collectively produces 6,000 pounds of produce, and we distribute that to this community through our community-supported agriculture. And we are building workforce development bridges. This meeting would not have happened without the help of our ICANN interns, our technical theater interns. We have a technical internship program that teaches young people, 15 through 22, to put the podium up, get the mics ready, turn the lights on. They are the ones that are doing the front of house. This program will help them not only build on the skills they know now, but transfer those skills to other places in this great Washington region. So I don't want to say too much. I think I've said enough, but I want to welcome you to THEARC, and I hope today would be not only edifying, but promising for the future. I'd like to, at this time, bring Wendy up to the podium. Thank you.
Thank you, Rasan. It is really our pleasure and an honor to be here. And I will testify on behalf of those ICANN interns. They really can. Because when I got here about an hour ago, those chairs weren't here. This podium wasn't here. We didn't have a, they work. They are amazing. So I really appreciate being here. Now, some of you, this is the first time that you've been at a BCR, Building Community Resilience Town Hall. And one of the things I want you to really understand is that what we have at the heart of our work is the community. It's not a coincidence that we have community in the middle of the name of this work here, because that is the center of this. And one of the things that we do when we are in 5 cities across the country is that we make sure that we are doing our work highlighting what we can build upon, not just highlighting the inequities, because that is certainly a part of the work, but we want to show the supports and the buffers that are already in place that we can build upon, the great work that is already here in place. We know there is resilience. We need to support that resilience. So this is a great opportunity for us to see what's already in place, what we can build upon, the great shoulders of those who have come before us. So speaking of resilience, this is about 2.5 years into this project, we have had the opportunity to work with 100 resilient cities in Dallas, which is one of our BCR sites. Most recently, some of you may be aware that Washington, D.C. was recently named as a 100 resilient city. And so we've had an opportunity to also be a part of that important work that's going on in this city. So as we get ready to begin here, I thought it would be really important for us to set the stage, not just from a BCR perspective, but to understand that BCR doesn't work in isolation. BCR works with individuals that are already doing great work in the city, across the city. And so I want to introduce Kevin Busch, who is with the Office of the City Administrator, but most importantly, he's our city's very first Chief Resilience Officer. He has extensive experience building coalitions that design and execute award-winning resilience and threat assessment initiatives. He previously served as a community planning and infrastructure supervisory resilience specialist. I just love that. Resilience is everywhere. At HUD. Well, in this position, he led HUD's first ever team dedicated to resilience policy, risk reduction, community engagement, and infrastructure. And as you'll learn today, these are all important themes of the work that we're also doing across the country in BCR. So it is my pleasure, my honor, and fully excited to introduce Kevin Busch.
Falling mic here. Hang on one second. All right. Well, good afternoon, everybody. Thank you, Rasan, for hosting us here today. It's always good to come to THEARC, one of my favorite projects in DC. If we had 1,000 of these across the country, we'd be in a lot better place. And then also thanks to Wendy and the folks at the Building Community Resilience team for the work that they do with many of my partner cities, including Marisa from Dallas. I'm happy that you're in our city today. So I would like to talk a little bit about the 100 Resilient Cities Initiative, how DC got to be in this network, and what we're focused on and what we've been up to thus far. So first off, let me start by talking about how DC and the rest of the cities in the 100 Resilient Cities Network view the term resilience and urban resilience. A lot of different folks have different definitions of the term, being public health practitioners and coming to an event called Building Community Resilience. You undoubtedly have your own working knowledge of the term resilience. I myself first heard the term when I was working on Hurricane Sandy recovery from the folks at the National Security Council who got mad anytime you deviated from the term as defined in Presidential Policy Directive number 21. So they might be mad hearing me talk about resilience now. But the way we view it is really based off of two concepts that I'd like to introduce into this discussion to talk about what resilience is. The first is shocks, and the second is stresses. And so acute shocks are the things that you might think of in the traditional emergency management context, whether it's a wildfire, a hurricane, a flood, but it also includes other sorts of shocks that aren't strictly emergency management shocks. In DC, that could be a government shutdown, right? There are 200,000 jobs in the district that are directly federal government jobs. I was a Fed in I guess it's not the last one anymore, but the one that lasted 2.5 weeks. I ultimately got paid for those 2.5 weeks, but a number of folks that were contract employees did not. And so they lost 2.5 weeks of wages. That is a big shock on our economic system as a city. And the only way you can really plan for these acute shocks is to also look at the chronic stressors. And these are the day-to-day, everyday disasters that we struggle with on a regular basis. Things like chronic homelessness, the high cost of housing, stressed transportation systems, you name it. Our ability to deal with and respond to the to the acute shocks is entirely dependent on how well we deal with the chronic stressors. And so there's a technical definition of urban resilience up here on the screen, but at the end of the day, the way I view it is, what we're really talking about here is the immune system of the city. How healthy are we? How able are we to respond to the big changes that come our way? And so a little bit about 100 Resilient Cities. We joined late into the game. We're around 3 city. We're one of the final 100. I think I was the last American CRO to be hired in the network. Kind of fun. So following on some great footsteps here. And what this initiative was launched by the Rockefeller Foundation at their 100-year anniversary. There's a theme around here around 100, right? And Mayor Bowser led a team to apply so that DC could join the 100 Resilient Cities Network. We're now part of this global network. The mayor of The Hague was actually in Ward 8 just last week, touring a number of sites, so we have a lot to learn from each other and other cities in the network. What the program is all about is planning for greater urban resilience, to strengthen our immune system. And a key component of that is the development of a resilience strategy, which is the process that we're embarked in right now. It's a pretty long, actually it's a pretty short process. We're about halfway through. I only started in August. And the first step, if we take this immune system metaphor further, it is going to the doctor and getting a physical. So we talked to a bunch of people. We talked to about 500 folks. We interviewed district agencies. We interviewed deputy mayors. We did a scan of existing work within the district. So, what activities is Office of Planning doing? What activities is DDOT doing? How many different citywide plans do we have, et cetera? We also talked with the folks at Homeland Security Emergency Management to get a better understanding of the that we plan for on a regular basis. And we just did some regular old desktop research. So knowing that a number of you are visiting DC for the first time, perhaps, or maybe the second time as part of this Building Community Resilience conference, I figured I'd give you a little taste of some big trends that are going on throughout the district. So if you don't already know, DC is not just a city. We're a city, county, and a state as well. So we have 35,000 employees, which is a lot more than your typical city, right? The city of LA has about 3,000, and they have more people living in it. But at the same time, we have a lot of complicated jurisdictional issues to deal with. The budget still gets submitted to the president and the Speaker of the House for their approval. And we're the only nation in the world, democratic nation in the world, whose nation's capital does not have full voting representation in Congress. In addition, we do a lot of planning in the district. Since 2015, we have put out 25 different citywide plans. We read them all. There are 900 actions and 160 high-level goals in all of them. And we're a city that's growing. We've been experiencing a tremendous amount of population growth. We're at 700,000 now. We're just about to pass the state of Alaska, which will then make us larger than 3 states in the Union. But we only have 66, 67 square miles in which to put everybody, right? And the district is also experiencing a lot of economic growth, although that economic growth does not touch everybody equally. There are significant disparities that exist in educational attainment, in economic attainment, etc. And there's a slide on one of them. In addition, we have a number of talk about population change and economic change that we have to be resilient to. There's also a number of environmental changes that we have to be resilient to. A lot of people don't realize it, but the district is actually a delta city. Both the Potomac and the Anacostia are tidal rivers, so they're subject to sea level rise. And in addition, the district is settled on a geological plate, and so we have some of the fastest rates of sea level rise along the East Coast. And that's just one of the climate hazards. In addition, we can expect to see, I think about three times, I believe the number is, 90-degree heat days by 2035. So we're going to have a lot more heat emergencies to deal with. And we also have a number of disparities in public health outcomes as well, which I'm sure many of you are aware of, given the nature of this conference. Housing is and remains a significant struggle for a lot of folks, and like most things, there are also disparities along income and race. And so, as I mentioned, we've been, in addition to the desktop research that I just kind of skimmed through, because I only have a couple minutes with you, we've also been talking to a lot of people, and what we're hearing is that there are a number of shocks that we are already planning for and should be planning for. And I'll highlight the cyber attack one because Teresa and I's colleague in Atlanta has been struggling with this for the last month. It's not something that I think a lot of people think about on a day-to-day basis, but the city of Atlanta has basically been crippled by a ransomware attack. You can't pay your 311, you can't call 311, can't pay your traffic tickets, and you can't respond to jury duty summons. And so our ability to deliver basic city services is threatened by things like cybercrime. We also have a lot of chronic stresses that we need to deal with. We're a growing city. We need to do so in an inclusive way and leverage that economic and population growth to address some of these disparities that have remained persistent over time. And so the process that we're in right now, we did this kind of, go to the doctor, get a physical, and now we're diagnosing some additional tests, if you will. Let's keep that immune system metaphor going. So in the spring and summer, we're going to organize around a set of 5 big questions we have about the district's resilience. The first goes back to that earlier slide I showed you about all of the plans that we have underway, making sure that as we go out into communities, as we engage folks, they understand and feel that their voices are heard, and don't just make it into a broad citywide planning document, but also into the back-end bureaucratic governance that, frankly, I get jazzed about. Does it make it into the capital plan? Does it make it into the operating plan? How are we tracking it in our performance processes, et cetera? How do we coordinate the bureaucracy, right? The second is around how do we institutionalize climate action. We've made some very aggressive goals as part of the C40 network. We're going to be carbon neutral and climate resilient by 2050. And we're one of the few cities of our size that's climate office is not hosted in the mayor's office. So how do we really institutionalize considerations of climate change? throughout everything the district does. The third is around creating access to opportunity in all neighborhoods. And this is really the understanding that there is no single agency that is responsible for helping our residents be able to climb the economic ladder. But it really takes a whole of government approach, and I would add into that civil society, knowing the role that nonprofits play as well. So how are we best coordinating among these different efforts to make sure that our residents are able to take advantage of the economic and population growth? The fourth is around responding to and leveraging technological change. There's three components of this. One is the threat of workforce automation and what that means for district employees in the district. The second is what I talked about earlier with Atlanta, as we become more interconnected and rely more and more on technologies, not only in how city government delivers our services, but in how our wired our homes are, how we move throughout the city, et cetera. How does that increase our vulnerability to cyber attacks, et cetera? And then the third component is, and if you've spent any time, I believe some of you did tours as part of this event yesterday in the district, you've undoubtedly see the diversity of options we have for getting around the city, whether it's dockless bikes, electric dockless bikes, dockless scooters, docked bikes, Lyft, Uber, the list goes on and on and on. So as we advance in technology and how people and goods move throughout the city, what does that mean for how we manage it? And then the fifth one is not thematically based, it's place-based. And that's really recognizing that it is the year of the Anacostia. And how do we leverage that excitement to make sure that we fully honor the resource that river is and make sure that it delivers all the services that it should to our residents. And then we have two cross-cutting themes throughout each of these discovery areas. One is acknowledging the amount of disparities that I just went through there really quickly earlier on, but how do we advance racial equity in everything we do? And then the second is really leveraging the fact that we are the nation's capital, that we host so many national and international organizations, and how can we get them to focus a little bit more on local DC and lend the tremendous amount of weight and expertise that they have into DC. So we're organizing around all of these areas in the spring and summer, trying to deepen our understanding about these big questions we have about resilience, and that will eventually feed into what makes it into the resilience strategy. If you're interested, you want to figure out how to get involved, or if you're going back to your hometown and want to see what it is we're up to, please do stay in touch. We'd love to hear from you. With that, that's it. I know that another part of this night, I will add one last thing, is I think you guys are all going to Ben's Chili Bowl at some point after this, which is pretty exciting. I'm originally from the Detroit area. We've got Detroit chili, Jackson chili, and Toledo chili, and I have to say that of all of those three, even though I'm a native Midwesterner, Ben's chili takes the cake. So enjoy, and thank you for having me here.
Thank you, Kevin. You forgot one other important chili, and those of us in the room know what I'm talking about, right? Cincinnati chili, right? All right. Okay. Now, this is a great way to get started. I appreciate Kevin setting the stage for us to think about not only the work that we do, but what the work that is being done across the city, but also how that compares to the work across the country. So I wanted to take a moment to introduce you to building community resilience, what it's about, our work not just here in the nation's capital, but across the country. I also, before I get started, I want to acknowledge my co-conspirator who's in the room, Dr. Bill Dietz from George Washington University, who's also been very supportive of this work, but the university itself has also been, I think, an excellent community partner and an excellent example of the potential when we partner with our institutions of higher learning as well as our community, so bridging that important space. Also, you're going to hear from a number of voices from across the community here throughout this afternoon. I want to acknowledge some of the people that are in the room who aren't necessarily on the panel, but I really encourage you to share your voice. And that includes Cameron Wyndham from A.G. Racine's office, as well as Calvin Smith from the Ward 8 Health Council from Bridgeport. So we've got some really important voices here that I really look forward to hearing from you. So for those of you who have not been initiated, I cannot be, I gotta be free. Okay, because I'm a hand talker. So I want to give you an opportunity to really understand building community resilience, what we're doing across the country, and the potential for what we have to do here in the nation's capital. So let's talk about resilience. Let's talk about BCR. let's talk about it in particular, how it relates here in Washington, D.C. So when we talk about adversities, there are many faces of community adversity, not just here in Washington, D.C., but across different places within the city itself. D.C. is one of the cities, one of the country's most income segregated cities in the nation. I like to call it a great example, unfortunate example, of American apartheid. And we're going to talk about that in a little bit here. But this is just one statistic and one way for you to look at the divisions here. That this map here begins to show you the change in median household income just in 5 years. And as you can see, we're going to see a common theme here, this east-west divide here in Washington, D.C. So the west side, which is many people are familiar with our beautiful monuments, the White House, Georgetown, some of the neighborhoods of upper Northwest, this is where you've actually seen an increase in incomes. The lighter colors, there show us where we've had a significant decrease in income. And of course, that's where we are right now, where we're standing right now in Ward 7 and Ward 8. And especially hit hard are African Americans, those who are disabled, as well as those with lower levels of education. So these not only have these income levels decreased significantly, what we also find is that we have limited economic mobility. So what does that really mean? Well, you heard Kevin talk about the phenomenal economic growth that we're having here, the phenomenal population growth that we have here in Washington, D.C. And that's causing great burdens and stressors. That means there's more people. You heard 66 square miles of the city. At some point, the limits have to give. There's not room for everyone. And so D.C. is not alone in its struggle to balance both the growing population, but also making sure that that the growth is benefiting all and not just some. And I think this is a really great way of helping to illustrate that. When we talk about the change in median household income, we're also looking at, and I don't know how, I might be aging myself here when I start talking about DC Unmapped. So I don't know how many of you remember triptychs from AAA back in the 80s. If you're going on a road trip, you order your triptychs. Well, one of the things that they did, AAA did, if you were traveling to taking a road trip to DC, actually east of the Anacostia was not on those maps. We were literally unmapped where we stand today on those maps. So this is important, though, when you think about not only were we being ignored from those outside of the area, but even within the city. When you look at the metro map here, the access to metro is not nearly as equitable as other parts in the city. I'll give you a really good case in point. So if you were trying to go from point A to point B here, even from this facility here, the nearest metro station is Southern Avenue. Anyone want to tell me who's actually walked from here to the Southern Avenue station? Yes, Ambrose. Huh? And what's that walk?
It takes about 15, between 15 and 20.
Okay, so 15 to 20 minutes from this spot here. There's a spot up in upper Northwest. It's known as the Forest Hills area, Chevy Chase. And in some places in that neighborhood, you can actually have, it's equidistant to 3 metro stations. Van Ness, Tinleytown, and Friendship Heights. You can easily stroll, and within 10 minutes. So we're not just talking about access to certain services. We're talking about basic infrastructure inequalities here that then do limit an individual's ability to have economic mobility. So this is something that is intentional when we think about how our systems are made. It's not just about the service that we deliver to people, it's about the infrastructure that we build that people can access. And this is critical, particularly when we talk about this with regard to economic growth in the district. Because if you're down here where you have limited metro stops, this is also an area where clearly we don't have the growth in jobs, economic growth. So you have an inability to even get to the areas where you have the greatest growth in economic. So let's continue with this theme of apartheid in DC. So let's look at the median household incomes. Again, you have the highest incomes really concentrated on the west side versus the east side. Then you also have, not only that, we know that affordable housing is a major issue in the district here. But when you have the highest concentration of poverty And those individuals that are also in an area where they're paying at least a third of their income, their monthly income, just for housing, and housing that may not necessarily be of the best quality, you can begin to see some of the other inequalities that are built in this very segregated city. So, let's talk about growth. Let's talk about affordable housing. And let's talk about gentrification. So, gentrification, let's unpack that, because what we're really talking about is out-migration. We're talking about people literally being pushed out, but where are they being pushed out to? So for those of you who are not familiar with DC geography, you see a little diamond point there, that's Washington, DC. And you begin to see where people are being pushed out to. So those of us who live here refer to Ward 9. DC really only has 8 wards, but we refer to Ward 9, and that's PG County. And so we've seen over the last 15, 20 years, this migration of people getting pushed even from the Anacostia region up to Ward 9, or Prince George's County. The problem with that is that the resources that many individuals need to access are not necessarily in PG County. And we're also seeing migration towards Montgomery County, which also doesn't have the same bandwidth of offering of services to support individuals as we do here in the district. And what's more pernicious about this is the trauma that is associated with the loss of place. We're talking about a city that was once known as Chocolate City. That is now, the most recent book about this is about, it's called Race, Politics, and Class in the Cappuccino City. Anybody a coffee drinker? Know the difference? So, and I think this really gets to the heart of this issue, because we do have to remember we are talking about people with real heart, real history, real spirit. And so they're getting pushed out. Howard and Columbia Heights. I mean, these are areas that once were the Black Mecca. And there's nothing wrong with being integrated, but we cannot lose an entire history, an entire culture in the process. And that's what's happening. And that is extremely traumatic. And it's the trauma that is being laid on top of historical trauma, on top of the trauma of not being able to access the resources of this city that prides itself on being so vibrant, and yet it's not so for everyone. So I think I've done a good job of talking about the disparities here. We're talking about neighborhood disparity, racial disparity, and economic disparity. But I think these statistics also help you understand how this is layered upon the population. So I highlight here, and what is a particular concern for us in building community resilience, is what are we doing for the next generation? What are we doing for our children? What are we doing for our families? And so when you look at how many African American children under the age of 18 who are living in poverty and compare that across the other races, you should be breathless. When you look at how it all adds up for Black families in this city, you should be breathless. We should all be ashamed of ourselves. This is the nation's capital, and this is the best that this country can do. You've seen the zip code differences. Is it any wonder that you have a difference between life expectancy from the east side to the west side? That 16% of our youth are completely disaffected, not in school, not working. No, sounds like it's pretty much by design to me. So some of you may have picked up the data sheet that we prepare for Washington, D.C. to show you what these ACEs look like. So I've given you an understanding of the economic hardship. You know, we've talked about, you hear about neighborhood violence, and while violent crime is down in Washington, D.C., homicide is actually up in Ward 7 and 8. And actually, we had a span last month where you had 7 lives taken in the course of 10 days. You also have a disproportionate number of children in the district who have a parent who is incarcerated. I know that when I first started working with Lee Beers and Matt Beal from Children's National and Georgetown MedStar, Lee did a presentation, and she was talking about the proportion of female heads of household, Aesthetic and Anacostia. And it was a percentage that was over 50%, over half. And I naively said, well, wait a minute, where are all the men? And she quickly responded to me, a lot of them are in jail. And we know about the disproportionate sentencing, particularly for African American men, particularly hard hit in Washington, D.C. But it's not all bad. I do want to kind of preview that. But I want to, what I'm trying to help you understand is that when we talk about adverse childhood experiences, we cannot disentangle this from the environment, that the two go hand in hand. So it's not so much, you will hear from our healthcare and our public health partners today, but healthcare and public health can't do this work alone. We can't change our community. We can't change the outcomes without thinking about our infrastructure, about our systems. So it's not just about service delivery, but it's really thinking about all the systems that serve community. So how do these things add up that I talk about? So we're looking at the association between all of these adversities and how they literally get under the skin and result in some of these outcomes, negative outcomes that we see in individuals. And just for those of you that aren't familiar with the ACEs science, part of the reason why we use a tree as an analogy in this work is because what the toxic effect, particularly on the developing mind of children, is just like taking a pruning shears to a tree. So what you see on top there is what should be normal brain development. And so this is when a child is in a nurturing environment. Parents aren't stressed. They have time to read to one another. You have caregivers that are there on a regular basis during the day. You have food on the table. You have a safe place to sleep. This is what normal brain development looks like. But for a child growing up in many of the conditions I described, you're seeing brain branching that is stunted. That is the effect of toxic stress. It's real. It's not just how you feel. It's how the body chemistry literally changes. Physiology changes. Your genetic makeup can change. It gets under the skin. So this is just another way that we use the tree to really help people understand when we're talking about judging the vibrancy of a community. It's just like looking at the health of a tree. So we know that you can see a tree, and if the tree is vibrant and green and the branches are strong, then you can assume that the soil is pretty rich. It's getting the sunlight that it needs. It has the fertilization that it needs in order to have that healthy tree. When that tree is not healthy, then we know, any gardener knows that your plants are only going to be as healthy as the soil in which they're planted. Same thing for our communities. And so what we try to do in BCR is to help systems understand their contribution to these outcomes, to the health of those branches, to the vibrancy of those leaves. So that's the work that we've been doing from George Washington University, not just here in Washington, D.C., but from many of our partners around the country. Oregon is now a state-level network. We started in Portland, and they're now state-level. Thank you, Kim Scott and the Oregon folks. We have Alive and Well communities that are based, it's a cross-state network that's in St. Louis and Kansas City. Dallas, Texas, woo-hoo. Also another 100 resilient city, and they do everything big in Texas. And in Cincinnati, we have, it's actually a cross-state network. So it's Cincinnati, Ohio, Northern Kentucky region. Many of you may be well aware this is also ground zero of the nation's opioid epidemic. So we've been learning quite a bit about strategies there that also affect us, and we'll be talking about how that has affected our work here in the nation's capital. And then we have our partners at ESON, who you'll hear from in a moment. It's a joint research project and program delivery project from Children's National and Georgetown MedStar. Sorry, Matt. As you heard from Kevin Busch, we have had the opportunity to start working with the Office of the City Administrator and helping them think through what is a public health approach when we talk about resilience. And then Unity Healthcare, we've been working very closely with the team at the Minnesota Avenue area. And you'll hear from a number of our other partners, including Ambrose Lane, who's here, who will speak to us later. So I want to help you understand, what we're trying to do, what we're trying to accomplish. But before, As Kevin did a level set with regard to resilience, I want to make sure that we're very, very clear on what we mean by resilience. So those of you, anyone who took a beginning physics class, knows that resilience comes from physics. And we're talking about an object's ability to bounce back after impact. But I want to be clear that we're not applying that term to the human spirit, because we are talking about real human beings. And yes, we're talking about a community. But I also want to make it very clear that when we talk about resilience, we're not just talking about bouncing back, because as I illustrated, these are not conditions that we want people to bounce back for. They've already proven that. Our communities have already proven that they're resilient enough to bounce back under these adverse conditions. What we really want to achieve is the ability to be able to bounce forward. And so when we talk about resilience, yes, you should be able to suffer an impact. That we cannot anticipate every bad event that could have happened in a person's life. But that bad event should not be deterministic of your trajectory. There should be proper supports and buffers in the communities so that individuals can bounce forward, can move to their highest levels of aspiration. And so that's what we really work towards, and working across systems to build this resilience. So when we talk about that, that means that a child that's suspended from school isn't necessarily right on the trajectory to wind up in juvenile justice. That's why we work with our juvenile justice partners in our other cities to talk about how do we become more trauma-informed? How do we begin to think about the adversities that not only is that child being faced with, but that community at large? How do we work better with law enforcement, inform law enforcement? How do we work with our school systems to really change the trajectory so that an ACEs score, so that a minor issue here and there doesn't necessarily determine that you're headed down the wrong path? And unfortunately, right now, that's too often the case. So BCR is a process. It's a means by which you can organize your work by creating the shared understanding. And that's what I was trying to do in this presentation, help you understand what's the problem that we're trying to solve and how do we go about doing this. And so that's looking at this state of readiness, looking at our infrastructure, looking at those pressure points, and thinking about how can we work together more collectively, purposefully, and meaningfully, and measurably. How do we bring together the multiple sectors, sharing resources? But most importantly, the reason why we're here at the ARC and the reason why we're always in community wherever we go in BCR is that community is engaged. Community has a voice in this. And community is providing critical data. It's not just our systems data, but it is also community data. Those that are actually living in the community have very concise, very precise data that we should be working with. And so that's where we start to begin to look at what's already in place. And so I wanted, I had a lot of really depressing statistics there at the very beginning, but there are things that we can build upon. This facility here is a great example. The internship program that Rasan talked about at the beginning, excellent example of how we're building resilience, how we're building programs that children can bounce back, use to bounce forward, actually. There are great programs that are even within our Attorney General's office, where we're diverting children from incarceration. We're thinking about how are we building on our skills, and we're doing it in a purposeful way. That's resilience in DC. And so that's thinking about how are we knitting all of these programs together in a really meaningful manner so that we can turn around some of these statistics that we're talking about in the city. So 76% of the households here can afford a nutritious meal. Now, can they easily access those nutritious foods? We know that's an issue, right, Ambrose? We just had to have a grocery walk over here. But 73% of parents say they have the emotional supports necessary. So how do we increase that and make sure that those supports are there for the parents as well as for the children? 50% of our children here have a medical home. That's a very good statistic. We can do better, a little bit better. So building community resilience is really focused on I call it the 3 Ps. Changing practice is the first one. So how do we link healthcare, public health, and community in a way that we are actually nurturing these positive environments? And these are some of the partners from across the country that are doing this work. How do we change program delivery? How are we more effective across sectors and program delivery? How are we working, the work that's going on in the Department of Youth and Rehabilitative Services, how is that purposely connected to the work that's necessary to maintain health for children once they're out of the juvenile justice system? How are we connecting then those social services that a family needs to make sure that that child is healthy? These are the programs that our partners have come up with to think about knitting across these multiple sectors. Oregon, you can look, sorry, Kim, I have to put you on the spot. In Oregon, you know, you can look and see, just Google 3 to PhD. This is a really phenomenal program. It's a school-based health program. It's a food pantry that's in the program. Community partners, including a major university, came together and said, this is how we're going to work in order to change outcomes for kids. But most importantly, policy change, which is really about systems change. So this work isn't about us feeling better about ourselves. This is literally getting under the hood and re-engineering systems. And so yesterday, BCR had its very first Hill Day. All of our teams went up on the Hill and they talked and shared with lawmakers about not only what are adverse childhood experiences, what are the pair of ACEs, but what we're doing, the evidence that we are showing around having this practice change and how our federal lawmakers can support this work. And I'm very happy to say that we had very pleasant, and not only that, there are hard and fast opportunities in the policy arena. We have some great support for trauma-informed practice. We have great support for, particularly in light of the opioid crisis, particular support for a lot of the rehabilitative programs, and not just thinking about punitively response to substance abuse, but really thinking therapeutically, not only what we need to do for parents, but what do we need to do for our children? What do we need to do for our community to turn this around? So that is BCR. And I want to give you an opportunity. I've done enough talking. I want to give you an opportunity to actually see BCR in action. So what I want to do is BCR, we're all about storytelling. So we have this saying in BCR that there are no stories without data, no data without stories. So we're constantly churning out videos to help people understand the work and see the work in action. And so I want to take this opportunity, the world premiere of our latest BCR video.
Building Community Resilience, or BCR, brings together cross-sector partners to build supports that will buffer against the pair of ACEs. That's adverse childhood experiences in the context of adverse community environments. BCR networks in 5 communities across the United States have the potential to reach nearly 25,000 children and families a year. These network partners are implementing programs that produce results and build resilience by providing much-needed social and emotional supports. In Cincinnati, the Parent Connects program does this by fully integrating parenting specialists into the pediatric primary care practice. These Parent Connect specialists help families address adversities such as parental depression and food insecurity. In Oregon, the 3 to PhD program at the Fabian School has reduced absenteeism and raised reading scores by applying trauma-informed practice into the classroom in all student interactions.
For us, this partnership meant a chance to really be boots on the ground in a system where we're looking at housing and trauma and food insecurity, full school-based health center, wellness clinic, dental care. It's a full spectrum of wraparound services for kids and families.
BCR's progress reflects innovative practice change in other sectors. In juvenile justice, Oregon's Multnomah County Court and Portland's Police Bureau have adopted new trauma-informed practices based on neuroscience, the pair of ACEs, and resilience, with the understanding that a child's behavior may be influenced in part by past traumas.
On top of all the trauma that the young people who come before us have often experienced, we also have the adolescent brain and adolescent development overhead, which requires additional specialized knowledge and understanding in order to be effective with young people.
Today, for me as an officer, I would say the role has flipped, where 80% of what I do is more traditional social work and problem solving and working with people, looking for those root causes of what's causing this behavior, and 20% of actual law enforcement.
BCR partners and their programs are producing results and sparking innovation in the field. But in order to make the cross-sector collaboration sustainable and scalable, a new approach for payment is needed. It involves mental health, it involves the education system, it involves public health, it involves medical care. It's just all these different players at the table, which is a great strength, but at the same time, there's no particular silo to put it in. And the funding streams so far have not addressed that problem.
If we can't get the healthcare system on some level to pay for things that support housing, then we're not going to be able to move the dial for these populations.
In 2015, the state of Oregon began requiring all Medicaid behavioral health care providers to become trauma-informed, creating financial incentives for prevention and innovations that build community resilience. Medicaid payment innovation is one example of how systems can provide financial sustainability and incentivize resilience efforts that will transform the lives of children, families, and communities.
This program is truly transformative, and the changes that we're seeing, the partnerships that are evolving, capitalize on a nascent and a committed group that sees these problems as significant ones that are going to shape the future. And in order to do that, people have to operate differently.
Operating differently to build resilient communities is building community resilience in action.
Good afternoon, everyone. My name is Lee Beers. I'm a general pediatrician here in Washington, D.C., where I take care of, I work at the main hospital across town that takes care of kids mostly from this side of the city. And I'm the co-director of the Early Childhood Innovation Network.
And my name is Matt Beal. I get to work with Lee in the Early Childhood Innovation Network and with Ambrose and some of the other folks that are here. I am a child psychiatrist at Georgetown. A lot of work in community settings, including schools and primary care, as well as mental health. Lee and I are going to speak for a few minutes about what we're doing with our network in DC, and I'm looking forward to hearing from. I'm recognizing a lot of folks' faces from Cincinnati and from Portland and from Dallas. I'm looking forward to meeting people from the new project. Good to be with you all.
Great. So we'll just take a couple minutes. We're going to take a couple minutes to tell you a little bit about our Project Early Childhood Innovation Network here in DC, and then we'll move into our very first panel, so you'll see me for a while. So about 2 years ago, Matt and I were fortunate to be able to launch this project, Early Childhood Innovation Network. And the thing that brought us to it, first of all, was that we both have worked with children in DC for a long, long time, over 25 years together, probably. So, and we have been continually struck by the strength and the power of the families we take care of. We were also struck by the amount of adversity and challenge that was around many of the children who we took care of. And so we came together and formed the Early Childhood Innovation Network. And our goal of the network is really to create a cross-sector collaborative approach to helping to build resilience in families, to improving, to bringing out the strengths in families, young families with young children 0 to 5, and really working together with our community partners and with the families around us and with our partners around us to build resilience and to strengthen relationships between parents and children. So, I'm going to let you see if there's anything you want to add to that.
Yeah, well, I think the best example is if we talk about a few of the projects that we're doing, and we can give examples. I think that Lee and I would probably both agree that we don't have a lot of great original ideas, but we know a good idea when we see one.
Yep.
And a lot of what we've been doing is bringing projects and concepts and strategies that are working either on a small scale in DC and trying to bring them to a larger scale, or things that are working in other cities and other places, and figure out how does that apply to DC? What can we learn from our partners and leaders in the community who can reflect back to us, what about this project, this idea makes sense for DC, for families and kids? What do we need to change it and tweak it and build it up so that it's most relevant and most useful for the families that we're serving, and so that we create real partnerships in all the places where we're delivering care. So we've got about half a dozen pilots going on. We can sort of tag team and walk through a few of the pilots. You want to talk about?
Yeah, sure. So our pilots really work across sectors. Healthy Steps is a program in intervention primary care where there's an early childhood mental health specialist and family champion embedded into the primary care clinic to tag team along with the pediatric provider, the pediatrician, to help support families of very young children. And so the way this works in practicality is that our Healthy Steps specialists and our family champions come together with the pediatrician into the visit, into the newborn visit with the family and the infant. And while I, as a pediatrician, may be talking about shots or breastfeeding or nutrition, the Healthy Steps specialist is talking about bonding and attachment and how are things going for you at home. And together we work to promote strengths within the family and help promote positive parent-child interaction. So if you want to see a Healthy Steps site, all you need to do is walk out the door and look around the corner. This is one of our sites. We also have another site down the road, which you guys may have seen on your tour at the Children's Health Center, Anacostia, the Big Chair. So over the past year, we've served over 400 families through that program, and we're delighted to say actually that we're going to be coming up to full-time here at the THEARC, and so really hope to build and increase that number of families.
One of the powerful things about Healthy Steps is that in addition to having a mental health specialist in clinic, we've got a community member who's a parent and who has navigated special education and early intervention services for his own children, and is now working as part of our team and is a family navigator and peer support worker for families who get services in clinic. One of the next places we're taking that pilot is to take that role of family-to-family support and take it into the neighborhoods that surround the clinics that we're working with. So we've got 3 neighborhoods that we're now working with that are here in Ward 8 that we're going to have a local organization, the Far Southeast Family Strengthening Collaborative, employ 3 community health workers. We're going to specifically focus on early childhood. And are really going to go block by block in 3 neighborhoods to figure out who are the families that have kids birth to 5. Are they among the 50% that Wendy referred to that have a medical home, or do they need to get connected to good pediatric care? Where are they sending their kids to preschool? How's childcare working out? How's parents' health and mental health? What do these families need that they're not necessarily able to connect with, or too overwhelmed to connect with, or have tried to connect with, and because of the bureaucratic complexities of getting your child into speech therapy or getting a housing voucher, all the things that may be helpful, to be able to family by family, block by block, work on those strategies and connect them back to primary care. So, OB?
Absolutely. So this model of integrated care is so promising from our perspective and really has such nice evidence behind it that we thought, why is this not happening in the obstetric clinic? Why is this not happening in the prenatal setting? And so while it's not the Healthy Steps model, because that's very specific to pediatric primary care, we're taking many of the same principles of integrating mental health services and health promotion services into the obstetric clinic, into the prenatal clinic. And so we've integrated a mental health support worker, a TIP worker, into one of the obstetric clinics here in Washington, D.C. that serves, at this point, almost everybody in D.C., given some of the challenges that are going on. And her role is really to help screen families for concerns and issues, and then help support them there within the natural setting, so that they can start their pregnancy and start their time with their infant in the strongest place possible.
We've got partnerships with a number of early childhood education centers as well. So we're really trying to bring together and weave together health and education in all things early childhood. We're doing some work that is parent-facing in schools. So we're particularly focusing on mindfulness as a strategy for parents. It's something that parents that we've worked with over the last half dozen years have shown enormous interest in. And so what we're doing is having a group of mindfulness instructors or expert instructors who are also Ward 7-8 residents teach mindfulness skills to parents in their kids' preschools. And we're doing it in group sessions. It's a very trauma-informed and trauma-focused, peer-supportive way of learning basic mindfulness skills with a goal towards getting at parents' own emotional regulation, reactivity, sense of connectedness with their kids. We're seeing really, really strong effects so far. We're about 40 or so parents we've run through several cycles of this work. What's really interesting that is emerging organically is that parents are so interested in these strategies that they're telling us that they're teaching it to their mom, to their sister, to their cousin who's also taking care of their kids. And there's enormous potential for natural leadership within these parent communities. And so we're in the process of developing is a series of trainings that sort of go by levels. So the parents eventually will become facilitators, mindfulness teachers themselves. See an opportunity both for professional development, for personal development, and for leadership within communities to spread these very, very applicable, relevant, secular, but really, really spiritually powerful skills around managing our own emotions moment by moment. That's something that has a lot of promise. We're looking to scale that to a second site in the next few months. We're also doing mental health consultation, which is a really promising strategy that's been using Head Start for years as a way to improve teachers' knowledge, skills, abilities around addressing early developmental mental health challenges in kids. And we're going younger and younger with that work. So we're working with schools that are serving kids as young as 3 months and developing curricular approaches and also non-curricular, just classroom-based approaches for providing consultation around early development for kids that are in these early education settings. And that's between those two programs, we've reached about another 600 or 700 kids and families over the last year.
So maybe I'll kind of close this out by, we really think of our work in sort of three, when we conceptualize our work, we think of it in really three big buckets. The largest bulk of our work to date has really been our innovations, what we've been talking to you about right now. We also see ourselves having a large role in education and technical assistance and really sort of contributing to the network and building up the supports within the network together. And then the third piece that we really see ourselves as playing an important role in is the policy and advocacy side of things. So we started about 2 years ago. We've really been building up our innovations, and we've been learning a lot from the work that we've been doing and a lot from the children and families we work with and a lot from the leaders who we work with. And over the next several years, our hope is really to take the work that we're doing and use it to push change both locally and nationally. So this is what we hope that all of you, we can learn together from all of you and make a difference nationally. So Ambrose, do you want to add anything? Yes? Okay. We did well. Thank you. Matt.
No, so I think Wendy, we're transitioning to the panel now.
Yep, I am bringing my panel up, my colleagues. So I'm delighted to bring up and introduce you. And I tell you what, why don't you guys can come up here, and while you guys settle, I'll introduce you, and then we'll move right in. Leah, are you going first, or is Wendy? You going first? All right, awesome. So on the and Jenny get themselves settled, I have the great pleasure of introducing our two panelists, and then I'll come sit down and join them, and we'll moderate their discussion afterwards. But we're going to start with Dr. Bodrick. Mia Amani Bodrick is a board-certified pediatrician in Washington, D.C. here. So again, delighted to have her as a colleague. Dr. Bodrick most recently served as a pediatrician at Unity Healthcare, the largest primary care agency in the District of Columbia metro area. As a pediatrician there, she was the site lead of the Building Community Resilience Collaborative, which you have just heard about. She also served as a physician leader to establish Unity Healthcare's first formal medical legal partnership with the Children's Law Center. This collaboration allows healthcare providers at her healthcare center to work side by side with an on-site legal team to provide services for families in areas such as education, housing, and insurance. Dr. Bodrick's areas of interest include childhood obesity prevention, global health advocacy and policy, addressing adverse childhood experiences, and toxic stress. She's a co-author of the American Academy of Pediatrics 2017 Policy Statement on Human Trafficking, Global Human Trafficking, and Child Victimization. She is a member of the AAP American Academy of Pediatrics, section on International and Child Health, and the DC chapter of the AAP. She has her doctorate in medicine from Meharry Medical College and her master's in public health from Emory University and Bachelor of Science from Hampton University. So Dr. Bodrick's going to start us off, but I'm going to actually introduce both of you
Okay.
first, and then we'll be able to flow smoothly. Dr. Vinny Choksi is a general pediatrician at the Goldberg Centers for Community Pediatric Health at Children's National Health System, where she also serves as the co-medical director of the Healthy Generations Clinic, which I just have to add is near and dear to my heart as a former director of that clinic. So I'm delighted to have that Vinny has taken ownership as well as Hope. I don't know if Hope is here, but Dr. Choksi is an assistant professor of pediatrics at the George Washington School of Medicine and Health Sciences. Her research interests are focused on adverse childhood experiences, trauma, and social determinants of health, specifically how to train providers in communication regarding these sensitive topics. She's also part of an interdisciplinary collaboration to develop a hospital-wide trauma-informed approach at Children's National Health System. She has a passion for teaching medical trainees, and this academic year is a part of the Master Teacher Leadership and Development Program at the George Washington University. So I will pass this over to you guys, and you can choose if you want to stay down here, come up here. You guys will-
Okay, sure. Go ahead and get started. Good afternoon. How's everyone doing? Good, good. So I guess I'll start by talking about how I got connected with BCR, Building Community Resilience. I first met Wendy, I think this was 2015, or 16. It's been a while, at a networking event that was hosted by the Rodham Institute here in DC. And we initially were working together on a grant that partners academic institutions with community organizations. And although we didn't get the grant, I was fortunate enough to be invited to join the BCR team. I introduced myself to her as a pediatrician in Ward 7, which I'm not going to belabor the point because Wendy has done an awesome job of explaining the layout of DC. But the clinic where I worked was in Ward 7, which is east of the Anacostia River and a little bit north of or northeast of where we are right now. And I started working there straight out of training. I was overwhelmed, to say the least, at all the challenges that I faced. And I was also really struck by the strength of the families that I worked with. It's hard to put into words, especially coming from where I was coming from, Orlando, Florida, and then to come to DC, and I'm not from DC, and all the challenges that my families faced and how they were able to continue to thrive in spite of that. And so I wanted to do something outside of direct patient care, more on a community level, to better serve my patients. And so we did a lot of brainstorming, and after many months, we decided the best way to do that would be to do a focus group. And so last summer, we did a focus group with both patients, who were actually the parents of pediatric patients at our Minnesota Avenue site, and then also clinical providers. That would include physicians, nurse practitioners, and social workers, to try to get an idea of what were the challenges or stressors or other factors that affect our community's health that are outside of what we could talk about in a 15-minute session. So for the patients, they revealed a lot of experiences, and I have to say that Wendy is the one that conducted the focus group for the most part, and there was a great level of trust that they had almost immediately. The sessions were all done in Unity, and our patients talked about a lot of experiences that affect their health. Some themes that came across were community violence. So we had a very lively discussion about how just going from home to the metro stop can be stressful, getting on the bus, getting on the metro, dealing with police officers, sometimes not always in the best way, how that can create stress. Job insecurity was another theme that came up. Housing insecurity, we've already talked about how expensive it is to live in the district. So imagine if you live in Ward 7 and 8, most of my patients every 6 to 9 months, they're moving somewhere else, and they're usually not places that they own. And then a lot of issues with education and getting the right services for their kids, and how do they navigate this, very convoluted system of education and special education in DC. Almost universally, all of our patients expressed, or our parents expressed, an interest in living a healthier lifestyle. And they were very interested in how we, as their medical home, could help them live a healthier lifestyle. And
a lot of these things we as clinical providers knew, but what you have to understand is that a lot of the clinical providers that provide care for patients at Unity and other sites east of the river, we're not necessarily from there. And we're not necessarily from DC. So we, in our mind, have an idea about what we think is best for our patients. And then once we have a real conversation, we realize that it's not always the same. So that's one thing that came across in our focus group, is that we were just very frustrated about the lack of time that we had to really make a real connection with our patients. I mean, most patients will come in and spend 45 minutes to an hour, hour and a half waiting in the waiting room, and then they come back and someone asks them questions, and then someone else asks them the same question, and someone else asks them those same questions again. And then by the time they get to, to us, there's 5 minutes, and we don't always have time to get into the heart of a lot of the issues that we talked about. And so what we end up doing a lot of, especially in under-resourced areas, is doing a lot of referring. And so this is too much for me to handle in 15 minutes. Let me refer you to social work, or let me refer you to an attorney, or let me refer you to this organization. And so once we kind of gathered all the information, we realized that we were doing a lot of referring, and we didn't know if that referral process was effective or if it was working efficiently. There are a lot of well-intentioned nonprofit organizations in these areas, but we're not sure if, for instance, if I had a patient who said that she wanted her child to get speech therapy, and I referred them to a certain resource, a lot of times it never comes back to me if that family made it to that resource or if that resource worked for them. And then a year later they come back and nothing has happened. So it's very frustrating for both the families and for the clinical providers. And so with the help of BCR, and especially Daniel Chin, which I don't know where he is, but he's awesome. He developed a EMR, or electronic medical record analysis plan. And we were looking at all the information that we get, because we screen for so many things. We're screening for depression, we're screening for socio-emotional needs, we're screening for food insecurity, housing insecurity. And then that information is distributed different places, but is it being distributed in an effective way? And so that's kind of where we are now with our plan, is that we've developed it, we've presented it to leadership, and for anyone in the healthcare setting that has worked in EMR, you know that making any sort of adjustments or practice change when it comes to electronic medical records is a very slow process. So we're just at the point where we are trying to implement that change. But I think what was the most beneficial about this experience was being able to speak to the community members and have a real conversation with our patients about things that are going on in their lives.
And then we'll move to questions for the group. Does that sound like? Yes.
Oh.
I'm actually. Hi everyone, I'm Vinny again. I'm actually going to stand so I can see my slides, and so that I'm not sitting right in front of them, though I'm actually not that tall, so I actually probably wasn't blocking them. So I'm going to talk a little bit about an initiative we have at Children's National. I am lucky to work with Lee and many other folks in the room, and so there's lots of cool, fun stuff we're doing at Children's, but specifically for this, I wanted to talk about a hospital-wide trauma-informed care intervention that we're doing that really has to do with education. So how do we create practice, program change? I think those are the P's to using. How do we create practice and program change using education? So I know that everybody in the room is familiar with this slide, but I always like to start here. You guys probably all know that these are the 10 original forms of adversity or forms of childhood trauma that were examined in the seminal Kaiser study years ago. This study looked at 10 types of trauma, looked at it in thousands of individuals, and showed to me 3 main things. The first thing, ACEs are common, right? So 2/3 of the people that they studied, again, this was 17,000 people, had at least one ACE. The next thing they showed is that they cluster. So if you have one ACE, you are about 80% more likely to have a second one. And then the third thing they showed, which is most important to us as providers of healthcare, is that these ACEs can have a long-lasting effect on your health, right? So that was truly a tremendous finding. And subsequently, there have been hundreds of studies that have been done as a result of this original study. And those studies have shown a few things. So one, that the mediating factor is largely stress, so toxic stress, and Wendy talked about that. The second thing is that it's not just those 10 forms of adversity. There are many more that we have found, and so those can include racism, bullying, immigration. Many of us in the room are familiar with this. The next thing is, which is important to know, is that this is not, this is not all bad news, like Wendy was saying, and that's why we're all here today. If we can screen, if we can do different types of intervention, we can build resilience, and also we can put in some protective factors to maybe sort of break the intergenerational cycle of trauma. So all of this, for me specifically, to say that it was a call to action really would be an understatement. I basically see my whole life through a lens of ACEs, including my friends and my poor husband, who hears about it all the time. But really, I wanted to know, what does this mean for us in Washington, D.C.? I did my residency training in D.C., and I've stayed on as an attending at Children's National. And so what I have here, and we may have seen this data already, but just in Washington, D.C., this is the 2016 National Survey of Children's Health Data. Wendy presented some of it in the diagram that she showed during her presentation, but 47.1% of children in Washington, D.C. have exposure to at least one ACE. And this was picked up in places like the Washington Post and other places that, sort of media sources. And that was helpful for me because I really wanted to go big with this. So I'm fortunate to call Lee Beer as one of my mentors, and she has taught me to go big, right? So we need to do sort of small changes, but we also need to think about how we may be able to involve our partners and folks who may not ordinarily be thinking about this, or may not be viewing specifically, for example, healthcare from a lens of trauma. So how do we mobilize folks? And we mobilize folks with data. So I started with this data. And the next way that we mobilize folks is through education. So Matt Beal probably doesn't remember this, but he said that to me about 3 years ago, and I've been quoting him ever since. And now he's actually in the room, so he's here to see it. But you can't actually expect folks to really get on your bandwagon and understand why change is necessary unless you help them understand why it's necessary. So what I did was I reached out to some of our nursing leadership folks over at Children's National. And the reason why I approached them is because many people know that there's sort of an increasing dearth of mental health resources in this Washington, D.C. area, unfortunately. And as a result of that, our Children's National emergency room was seeing more and more children who were being titled as, the difficult patient or the behaviorally disruptive patient. And I kept hearing that over and over, and it was really making me frustrated because that's not really a trauma-informed way to think about the situation that's going on. And it was to nobody's fault. It was just, people were working within a bad situation, limited resources, and trying to figure out how we might be able to work to help those patients. And so I joined those folks who were thinking through that and said, here's this science that we have to think about, and I expect that the patients who are seeing in the emergency room and saying that they're behaviorally disruptive, I'm imagining that they likely have a high proportion of what we call ACEs. And so through those initial meetings, we were able to form a work group that includes myself and 3 other nursing leaders across the institution under the mentorship of Lee Beers, like I said, and a few other nursing leadership folks. And we created an institutional goal for Children's National. So to advance nursing knowledge, skills, and practice, to improve the understanding and responsiveness to the impact of trauma and adversity among pediatric patients and their families. So that goal was created, so it was an educational goal, right? But before we had the educational intervention, Lee mentioned in my introduction that I'm taking a teaching and leadership course at GW. And so what I learned there is that you can't really do an intervention unless you understand what the needs are of the people who you want to teach. So we searched high and low for a survey that might be able to help us understand the knowledge, attitude, skills, practice of our staff at Children's National. It's actually pretty difficult. Lots of the surveys that exist out there are either really focused on mental health specifically, or they're focused on trauma that isn't this type of broad definition of trauma we're using through SAMHSA. They're focused either on physical trauma like breaking an arm or a leg, or they're focused on sort of more traditionally known as sort of post-traumatic stress disorder symptoms. And so was actually through a nursing doctoral student that we found a survey. We reached out to her. We asked her if we could modify her tool, and she agreed. We sent out the survey hospital-wide, and we had 620 people respond. And up here, you'll see it was about over half nurses, but then we had physicians. And then the other category, the 18%, was we had patient care techs, we had environmental services staff, security staff. It went hospital-wide, so anybody was able to respond to the survey. And then what did we see? We saw that 50% of respondents had not had any education related to trauma-informed care. Also, about half of respondents didn't understand the critical need to understand the details of a patient's history of non-physical trauma. Over 70% did not have a comprehensive understanding of what trauma-informed practice is. And then lastly, 80% didn't feel that they had the resources that they needed to engage actively in trauma-informed practice. So this was pretty striking for us. And you know, the data existed for all the questions, but these were the ones that we thought were the most informative. So what did we do from that? We wanted to figure out a way to help to educate this group of people who had completed the survey and also to meet the institutional goal that we had set. So we partnered with SAMHSA and specifically the National Center on Trauma-Informed Care. And actually, lucky for us, two of the physicians, or one physician and one PhD who work through the NCTIC, they actually are based in Annapolis in Virginia. So that was pretty lucky for us because they were able to partner with us and come to do 7 half-day sessions for us at Children's, which was wonderful. And we had greater than 700 hospital staff trained. And so the nurses got CEUs, the physicians got CME, and we had the educational sessions that had the 2 objectives that are listed above here. I will just say that one thing that was really wonderful about this partnership is that these folks from the NCTIC, they go all over the country really to give this training. But what they had told us is that they usually go to, for example, one juvenile detention center, or they go into one sort of psychiatry unit within a hospital. And what they were really excited about is that it was one of the first times that they had a full hospital that was approaching them and wanted to really think about how to perform trauma-informed care, trauma-informed healthcare, I should say, not only in the mental health sphere, but really thinking about it from the emergency room to the outpatient clinics to the inpatient wards, including the high-level care settings like the ICU and the NICU. So that was exciting for us to partner with them. And so the key accomplishment was obviously that we had 700 of those folks trained. But I wanted to say that another key accomplishment was that we started to, with the help of BCR, we started to think about, okay, how do we have other hospitals sort of follow this same initiative and follow the same trend? And lots of folks, when we presented in Portland, were interested in that. So how do we use the same tool and what do we do with that? So Nia gave her shout out to Daniel. He wasn't here to hear it, but I will give another shout out to Daniel, who really has been working tirelessly with me and my colleagues at Children's to help us validate this tool so that it's not only helpful to us at Children's, but that other folks who are interested can then use this tool to do a baseline needs assessment of their population, their staff at whatever institution they may be working at, so that they can then tailor an educational intervention based on the results that they get. So that is in process. I don't actually understand any of these words, but if you have any questions about it, Daniel can help you. He wrote this slide for me. All I see is that it says validated survey. So I'm like, yeah, that's the money. So that's what we need. And Daniel will answer any other questions. And then the last couple of things I'll end with is that we do have post-intervention data, which is really cool, and we try to do match pre-post. So just a couple, I'll show just a couple of the pre-post answers. So I have all the resources I need to engage in trauma-informed practice. So the red is post-intervention, and you can see just the agree and strongly agree go higher, so that's good. And then I have a comprehensive understanding of trauma-informed practice, same thing. You see more red than you see gray going towards agree and strongly agree, so that was exciting as well. So future directions and policy implications. So we're going to continue to partner with SAMHSA. They've come a few more times since they've done these trainings. And what we're going to do is sort of inform our practices by having them do departmental site visits. So what's the opportunity to be more trauma-informed in the emergency room? What's the opportunity to be more trauma-informed in our outpatient clinics? And then also getting divisional trauma-informed champions. So something that's come out of these trainings is that we've identified folks within each division that have reached out to us and say, I really want to be more involved. How do I do that? And I think when you're looking at an institution as big as Children's, you really need that. You need some champions within each sphere. Next, we're working on trauma-informed educational sessions and partnerships in the community. Lee knows that I'll basically go anywhere anybody asks me to at the drop of a hat because I've really been trying to scream the signs from the rooftops. But what's been nice is that Children's is in charge, I think that's the right way to say it, of the nurses at the DC public schools. And so partnering with them during the summer session when they're not as busy to figure out how we can create a collaboration with them. And then institutionally, we've really been trying to create a strategic plan. So now that we want to do this hospital-wide, how do we incorporate all of our separate divisions, and how do we decide how to develop systems to assess the impact of trauma, and what does that mean for screening, and what does that mean for the response?
Wonderful. Thank you, Minnie. So we're going to move now to a question and answer period. We've got a good chunk of time for questions, actually, because we'd really like to create a discussion. I'll go ahead and start off to give everyone time to think and gather their courage to ask some questions. But maybe, yeah, I'll start with you. Benny just talked a little bit about some of her hopes for next steps. And the data you have from Unity is really, I know, I'm not sure I'm actually talking into a live mic, but I'm holding it up here. So it looks good, right? So, okay, good. It looks good. No, it's fine. It's good. Thank you. Tell us a little bit more about, I know you and I talked earlier about some of your hopes for the next steps at Unity. What things would you like to see happen next?
So I think the ultimate goal is that we want the organization to become trauma-informed, a trauma-informed healthcare center, which is a big ask and takes multiple steps. So one of our first steps was our Emr Integration Plan, which in an organization that is often under-resourced, we have to figure out the best way to navigate that. And so that's what we're trying to figure out now is how can we implement this plan? Would that involve hiring more people, or can we use our current care coordinators? I have to shout out Trish Martin, who's helping to take the reign at Unity, and she had the wonderful idea of using our current care coordinators to help link us into to help us figure out if our patients are getting the proper resources when we refer them out. One of the other themes that came up that I didn't mention before from our focus groups was partnering with law enforcement and in community policing. And so, you know, in Ward 7 and 8, how can we partner possibly through the mayor's office and through the district with law enforcement in a positive way to sort of reframe the way that our community views law enforcement in the sphere of health. And so that could take different that could come about in a different way. One idea was maybe to do a podcast where we had, you know, a physician and a law enforcement official in the community there talking about important issues, because our community members see, you know, police officers like literally staked out in front of our healthcare center every single day, and they may never talk. And so that will be the first step. Those are some ideas. Yes,
Yeah,
I knew you wanted to.
But I think it's important you're talking about law enforcement. But one of the things that came out of our focus group was also that disconnect between when, because Unity Healthcare is also one of the largest healthcare providers to individuals both in adult and the juvenile side when they're incarcerated here in the district. And I think one of the things that we don't necessarily think about is that continuum of care from when you're in custody versus when you're in community. And I really would like for you to share that with this audience, because I think that's also a critical point that we should look at as far as collaboration.
So when I was at Unity, I had a decent amount of patients, mostly adolescent young males, but also females who spent some period of time in juvenile justice systems. And many of them had mental health issues or had been diagnosed with mental health issues such as bipolar, ADHD, or PTSD. And oftentimes are put on some pretty strong antipsychotic medicines. And so they would stay there in juvenile justice for any period of time, and then they would be transitioned care to me. And for the most part, the parents were completely left in the dark about any sort of health services their child received while they were in custody. And then they would get to me and have very little idea about what their diagnosis was or what they're being treated for or who they're supposed to follow up with. So we talked about, that came out in the focus group about, you know, having more data sharing between healthcare partners and the juvenile justice system as a way to provide better care for our patients, because there's a huge disconnect there. Yeah, yes, Ambrose.
I
promise I'll be nice.
Okay, thank you.
Just to piggyback off of your comments
Mhm.
about partnering with the police department.
Yes.
You know that DC has a stop and frisk policy, right? And that might make it a little bit difficult for communities to be able to trust police. Second, according to the fact that we have already passed the NEAR Act, they have not provided the data that by law they are supposed to provide in terms of recording the data for the stop and arrest or potential arrest that they make. So it makes it a little bit difficult. But what I wanted to circle back on was this trauma-informed care. And there was an effort for the district to become a trauma-informed city, but that hasn't worked yet. So my question is, what does it take? What will it take? And how will you define what a trauma-informed city would look like?
I don't have the answer for that. I'll be honest. Do you have?
Well, I was just going to say, I mean, I'm not sure if Wendy already talked a little bit about the, DC as a resilient city and the collaboration with the mayor's office. I can't really speak to that, but Wendy definitely can. But I think, not to say the same thing over and over, but I think it really starts with education, because lots of folks still don't understand what we mean when we say trauma-informed care, including my colleagues who I work closely with every single day. And part of that is because we work in a healthcare setting. And so when I say trauma, they think broken arm. So it's really breaking down that silo and barrier. But across the city, people are not really, we're not all speaking the same language yet. So I think it's really more conversations like this one to help people get on the same page.
Gavin's doing his job. Now, one of the things that I think is important is the use of the word care, because when we attach trauma-informed and then put care, it's implying that it only occurs in a healthcare or public health setting. And so I think that that's been one of the obstacles when we do talk about being trauma-informed. I think, as Benny said, the first thing is to understand, what does it mean to be trauma-informed? And then your delivery of service, how does that inform your delivery of service as opposed to the delivery of care? So in some, settings, it may be some sort of care, but in most of the cities, most agencies and providers across the city, it's going to be some sort of delivery of service. So as you saw in the video that we had earlier, where we saw in the Multnomah County with the judges and the police officers and really how it's been infused in their practice, they're thinking about, what does a trauma-informed practice look like? And so I think that's, as Benny said, it's really about the education, how we use these terms, and so that everyone understands what's the frame, what are we trying to accomplish, and understanding the brain science. I mean, that's why we're having a discussion such as this, so we can all have that common setting.
And I would add too, when you look at SAMHSA's sort of guidelines for developing out trauma-informed systems of healthcare, right? There's a lot of principles there that I think really are applicable citywide. Education is absolutely one of them, and that has to be brought anywhere a city resident touches should have some level of knowledge. But I think there's a couple other things. It's thinking about, how do you design your systems so that they don't re-traumatize children and families or adults who have previously been traumatized? How do you include the voice of your residents and the children and families within your city and community to design that system? And so I think some of those are some of the principles that would need to be applied, and it's going to look different in every agency, right? But it's going to be a top-down commitment to bringing that as Benny, we all kind of, it's changing the frame of mind of it's not what's wrong with you, it's what's happened to you. And so thinking about applying that frame to everything that we do is how we start to make that change. So we'd love to hear other questions.
Hello, everyone. My name is Yolanda Hancock. I am also a community pediatrician and a professor at George Washington University, and I'd like to shout out all of my students who are here. My question is, how do we move further upstream? I think it's very important that we are educated and screened for ACEs, but if we don't work to decrease the exposure, we will continue the same vicious cycle, particularly in a time period where children are inundated with messages through social media. I mean, if I wasn't a pediatrician, just a mom, I would have a fear, particularly if I had a Black son, just for him to leave my house. So it isn't just our direct exposure, it's a child watching the news, watching two black men handcuffed in Starbucks. So I'd like for you guys to talk about how do we collectively as a community not just educate other people, but really move towards decreasing our children's exposure. And Nia, one of the things that you mentioned was how our community sees the police, but we very rarely talk about how the police see our community. And that's also important.
I presented on a similar topic yesterday, actually, with Dr. Jones, who I think is from Mahari University. Right. No, Camera Phyllis Jones. Anyway, she said to me after she heard about some of the work that we're doing, you really have to not just think about that the ACEs are happening and pay attention to them. Certainly that's important, but you have to think about why they're happening to begin with. And so just to talk about the Generations Clinic for a minute, what the Generations Clinic is that Lee and I are both involved with is a teen top model. So we have our adolescent parents who we know are vulnerable, who we know from the literature have an increased risk of exposure to adversity. And we are taking care of them, but also their children in the same clinic. So the adolescent parent and their child are seen by the same physician and also the same social worker. So they could be seen for their health issues during the same visit, or they can come separately. But the idea is that we know the whole family. And so it presents a really interesting model because it presents with us an opportunity to provide interventions that are multi-generational and intergenerational. And to me, that's really interesting. And I have to be honest, I really don't consider myself a researcher. I'm a physician first and then an educator. But this work has really inspired me to do research because I think that there is a need for us to understand the interventions that our patients want to participate in. We can't, like Nia said, we can't keep giving all of the, in some areas we're saturated with interventions, but the engagement is not as high as we would like for it to be. And that's because we're unfortunately not involving our patients and community as much as we could. Lee and I just submitted a proposal for a study to do some semi-structured interviews with our adolescent parents and to really ask them, starting first, do they even understand what adversity means, but do they understand how that adversity affects their health? And also, more importantly, if they understand that their adversity affects their kids. We know that there's an intergenerational transfer of trauma, and if we could help these young adolescent parents understand the effect of their adversity on their young children, maybe that's an opportunity for us to start to do some prevention. So that's just one idea, but perhaps the answer is more research and more community engagement.
And I can just say, speaking about my patients, the patients that I had when I was at Unity, the families who I felt like had the most strength and were able to persevere in spite of all the challenges were the ones that had the most support. And that comes in different forms. So they may have felt, for some of them, they felt like Unity was that support. And that's where they came for everything. Even, we would have conversations about things, about housing, about school, about who's in the home, about violence. So, the medical home serves as the support area. For others, it may be the school system. This is where I went to school. This is where my grandmother went to school. This is where my children go to school. This is where I feel safe. And so, sort of harnessing those protective factors, whether they be education or healthcare, wherever that family feels like they're supported, is really important. And I don't think there's any one right answer. I think education is always the first step. But my families that seem to thrive are the ones that I feel like they're the most supported.
The research really, I'm sorry.
I want to recognize, I really want to answer your question directly because what you are talking about is that interaction with community police here. And that is something, as Nia mentioned, came up directly in our focus groups at Unity. And because of that, that actually inspired us at BCR to launch what we call the Root Causes Project, which I'm very honored to have James Peterson, who's a professor and a doctor at GW, who's leading that. And James, I'd love if you'd share a little bit about that project and our ongoing efforts to open up dialogue with Metropolitan Police.
Thank you, Wendy. Good afternoon. I am a research ethnographer at GW and teaching ethnographic research classes, and this is part of the team that I'm working with. Kevin Dwyer and Nick Luring and Kenny Barnes, who's in the hospital and couldn't be here. And we're currently engaging with the chief of police office here in DC to begin to have dialogues from different methods with the police here in DC, particularly in Ward 7 and Ward 8, to begin kind of learning the question that I think you brought up, is to get an idea of what the police think about the community. And so we'll be talking with, we pretty much set up through the IRB, but talking with the police on one side with in focus groups, and then also talking with youth 16 to 21 years old in the Ward 7 and Ward 8 area, and recognizing that there's quite a bit going on here in the city, attempting to generate some energy around law enforcement, relationship with the community. And I've been to, I don't know how many sessions, symposium, talks here in the city about police, community, and back and forth, but really trying to learn what police are thinking about community and how that thinking may be carried out in various situations when, you know, there's really not a lot of time to think, whereas you really want to learn, maybe begin to develop interventions and ways to talk and ways to talk to police, and then maybe talk to youth about how to deal with police, understanding what some of the potential perceptions are or ideas that they may be confronted with in those particular situations. So.
Thank you, James. I think we have like 2 minutes left.
Yeah, I was just gonna say, I think we have time for one more question. So, and of course now we've got lots of questions. You're in front, so I'm gonna let you take it. But I know our panelists are likely able to stay around a little bit afterwards. Great.
Thank you. I appreciate that. Thank you. This is certainly a wonderful town hall meeting, and certainly we have to take it from here. It's incumbent upon us to take this outside of here and continue the great work. My name is Henry Jones. I'm the supervisor for the city's newest unit on missing and runaway youth, formed by the mayor. STEP team is called, Strengthening Teens, Enriching Parents. It started in September. And basically every day I get a list from MPD of those who have been declared missing or run away. But as we found, and unlike LL Cool J about 2 summers ago tweeted all over the world that our youth were being abducted or snatched or taken, it's really not that. Now, once they go missing, they can get caught up in sexual trafficking, things of that nature. But by and large, we talk about adolescents who are hormones are raging wild, they're disobedient. Same thing all of us was doing at that age, trying to get away with things and being rebellious. So my team, we look at the triage forms we have, and we use the ACEs, we use the APGAR, we use the CAFIS system and all that. And I sent out social workers to the home to talk to the youth and to the parent to see exactly what's going on in the home. As you said, it's not, you know, basically what they did, it's what happened to them. So we err on the side of caution and say that all of them have been traumatized. That slide said 50%. No, we say everybody's been traumatized in some way, shape, or form. So my question, though, to you is, where does the youth right to self-determination ends and society's goodwill begins? And I don't want to casting aspersions and be disparaging against you, doctor, at Children's Hospital, but we had a situation going from generic to specific now, where a young lady, very promiscuous, thought to have HIV positive, was infecting a certain neighborhood because the other parents of 2 young men, 2 young boys, you know, singled her out, took them to get tested, and they were HIV positive, and led back to her. Went to Children's Hospital with the young lady, and she said, I don't want to be examined, and they couldn't examine her because she was 13 years old. And so in my mind, I had never heard of this before, and I'm saying, well, she's kind of like a risk to wider society, but she has rights and didn't get treated. So she was able to leave that day, and nothing was done. So how can we best collaborate with these situations like this? It might be at the legislative level with the city, possibly, but we all have to work together so we can get them the treatment that they need. I've been on board 36 years now. Anybody got 36 years with the government? So I'm the OG in the room, huh? Okay. That's not original gangster, that's old guy. That's right. But so all this experience that we have in this room, we can get things done, but we got to collaborate a little bit better than we've been doing. So I'm glad this is the start of something I see that we can continue, and I'm certainly on board with it. So thank you.
Yeah, no, that's wonderful. The work that you guys do, I've actually heard about it through some of my colleagues. It's really, really remarkable. I've been at Children's a little longer, so maybe I'll field that one. I think, I think it's a super complex issue, right? And I think there's a couple high-level things that I would say. One is that it is a really complex issue, and that when we face these questions clinically, there's a lot of things that go into it, right? Legality and the patient's right to determine their own treatment and whether they're at harm for risk or others. But I think the more important piece is that when you face these really difficult and complex issues in healthcare, is really thinking about how do you take a really multidisciplinary approach to problem solving, because it's sometimes it's hard to know what the right answer is, right? But so like if you and I and Ambrose and others all around the room are sitting together puzzling over these complex issues and how do we best take care of children and families in difficult situations, then that's when we're going to get the best answers, and that's when we're going to be able to best support children and families. And you know, right, the work you do, there's no easy pathway, right? There's no flow chart we can follow that's always going to apply. And so those relationships and that collaborative, multidisciplinary approach really, I think, is key. And so we look forward to working together. And as I said, I've heard good work about what the things that are happening in your office. So with that, I think actually might be a nice way to close us out and move us on to our next panel. Benny, Nia, thank you guys so much. The work that you guys have done is really remarkable. Those of you here who work in health systems know how slow and hard they are to move and how intractable they can be sometimes. And so the fact that you guys have made such remarkable progress in those settings and really changing the way providers care and think about children and families is really remarkable. So thank you for that, and thank you for your time on the panel.
Thank you. Thank you. So we have a tradition in BCR. Everyone that's doing this work, everyone that's part of community deserves a standing O. So we also need to stretch, so standing O time here. So we're going to move on to our next panel, and I'll introduce each of our panelists first and have them come and join us. I want to say that we're going to do this panel a little differently. Henry referred to OG as old guy. So I like to refer to myself as OSG. That's an old spiritual gangster. How's that? So don't be fooled by the Lancome. One of the things that is important is we want to mix this up and make sure that everybody, oh, you can sit. Thank you. Thank you. I just wanted to, let's just get it out there. I am old enough to say that I remember Donahue. Who here in this room remembers Donahue? So that's what we're going to do this next panel is more Donahue style. So we're going to have our panelists present. My colleague, Communications Director Sarah Baldoff, and I will be working the crowd, and we really want you to dive in because this is where we're going to start getting into the meat of the community work here, and we definitely want to hear your voice. So the first panelist who I'd like to invite to join us up front is Dr. Melissa Clark from the Medical Home Development Group. She's passionate, and kind of meets me in my passion there, about empowering individuals to be their own best health advocates and achieving health equity in minority communities. Currently, she is VP for Population Health of the Medical Home Development Group, establishing new healthcare facilities in Ward 7 and 8 in non-traditional sites like churches and apartment buildings to make care convenient. Go ahead and have a seat. And link individuals to the community resources they need to stay healthy. In addition, Dr. Clark serves as Vice Chair of the board and board member for 5 years at Unity Healthcare, the largest federally qualified health center in DC. You've heard from Ambrose Lane earlier. Now he's going to join us up front. Ambrose Lane Jr. from the Health Alliance Network is a longtime activist and community builder in the district here with over 25 years of leadership experience as an effective organizer, working directly with youth, elected officials, community leaders, and businesses. Ambrose is the founder of the Ward 7 Health Alliance Network, the strongest and largest DC community health advocacy group to advocate for residents of poor and low-income communities in Wards 5, 7, and 8, the issues of health equity, population health policy, and chronic disease prevention strategies. And last but not least is Marisa Perella, Mary Center. She's a licensed independent clinical social worker and a licensed clinical social worker in Maryland. She is a manager of the Mary Center school-based mental health programs, and most recently a member of the DC Task Force on School Mental Health. And as a mom of a 15-year-old, most importantly, we have sons who are working today at this event. So thank you.
Didn't realize I was up. Thanks. So I am actually going to take a page off the last panelist and actually stand so I won't be in the way, although I too am short. But my name is Melissa Clark, and I work with the Medical Home Development Group. And I came to this work, although I'm an emergency physician, one of my frustrations in my role in emergency medicine was seeing the cracks in the healthcare system and seeing people fall through them, and wanting to really try to work in a way that was outside of the clinical setting, but involved the clinical setting to really make sure that we could try to bridge some of those gaps in care. So today I'm going to talk about building resilience with individuals who are affected by opioid use disorder. And just a little bit of background about Medical Home Development Group. We're relatively new in the city, about 2 years now, but we have sites across all sections, all quadrants of the city. And we did that specifically because we want to live up to our motto, which is best of care close to home, really trying to make sure that care is accessible. So for example, one of our sites in Southwest in Ward 8 is actually in the first level of a 700-unit subsidized apartment complex, specifically, again, to try to make care accessible to those individuals that need it. And then across all our sites, we do adult, multi-specialty, and primary care. The site in Southwest Ward 8, we do pediatric, primary care, and specialty care. And then in 3 of the sites, we do office-based medication-assisted therapy for buprenorphine, using buprenorphine for opioid use disorder. And we're actually the largest opioid use disorder provider in the city. So this may be a news flash to some of you, to others, you may already know this, but DC is in the ranks of ground zero for the opioid epidemic. You know, many people thought, oh, this epidemic is happening in white America, in the suburbs, and in the rural areas, but actually DC is number 4 in opioid deaths per capita. And just to illustrate nationwide, again, that misconception that this is just happening in the white community, you'll see that whites and American Indians per capita have the largest number of overdose deaths, but people who are African Americans actually have had the steepest rise in opioid related deaths since 2015. So again, number 4 in opioid related deaths in the country, behind West Virginia, New Hampshire, and Ohio. African Americans in the city account for 83% of the deaths from opioids. And the deaths from opioids have surpassed that of gun violence in DC. Wards 5, 7, and 8, probably no surprise, are disproportionately affected, as are the hospitals in those areas, UMC and Providence, which see the highest percentage of both non-fatal and fatal opioid use disorder patients. So relating this now to, while we're here talking about resilience, these statistics closely relate to conditions in urban areas as the reason for these large numbers of opioid use disorder. But to understand how to promote resilience, we first have to talk a little bit about the problem and do a little bit of level setting. So first of all, I think it's important to understand one thing that historically has not been said since the initial opioid epidemic, which started in the 1970s in urban communities, which is that opioid use disorder is not a moral failing. It is a chronic disease. So just like diabetes, you wouldn't ask somebody to go cold turkey from food. You wouldn't ask somebody to go cold turkey even from carbs. So therefore, by extension, it's similar in opioid use disorder. It's very hard to get somebody or to ask somebody to go cold turkey from an opioid after extended use, and they truly already have been diagnosed with opioid use disorder. The standard of care is really medication-assisted therapy, which is providing medications that help to stabilize your body in terms of not needing opioid drugs and the actual physical withdrawal symptoms that people go through, to allow them to then return to some sort of level of function to address the issues that cause them to develop an addiction in the first place, which is where the pair of ACEs comes in terms of the trauma, the childhood traumas that are experienced, as well as the community experiences that individuals have, which then lead to ritualized comfort-seeking behavior, also known as addiction. And then I also want to introduce the idea of toxic transgenerational stress. I know we've talked about toxic stress today, but I wanted to point to two studies. One that was in 1944, there was a famine in Holland. And those individuals who went through the famine and got pregnant around that time, they looked at their offspring. And their offspring had alterations in their genes that correlated with higher rates of obesity, diabetes, and heart disease. And then a similar study was done looking at Holocaust survivors. And they looked at children of Holocaust survivors who were born after the event. And those individuals, too, had genetic alterations that correlated with higher rates of PTSD. So if they were exposed to trauma, they had higher rates of PTSD being developed, as well as hypertension and obesity. Now, what do those things sound like? They sound like the health disparities that African American communities experience today. And of course, those were self-limited events: famine, the Holocaust. Terrible events, but these are 400 years of events that are sustained until today. My colleague, Dr. Hancock, so ably just spoke to, mass incarceration and police brutality, and even just the psychological effects of seeing these videos on Facebook and television. So I don't want to sound fatalistic, though, that it's in your genes and so you're kind of stuck with it. I wanted to point to one other really important study that I think is very key, that looked at African American men who report being exposed to interpersonal experiences of racism. And those individuals who were exposed to the interpersonal experiences of racism then reported on whether it affected their self-image and their self-confidence, so whether they internalized it. And they found that those individuals who reported that it did affect their self-image had higher rates of changes, actually DNA damage to their telomeres, which are associated with premature aging, versus those individuals who didn't internalize it or report internalizing it did not have that same accelerated damage to their DNA. So far from this toxic transgenerational stress or even current stress that we go through being something that we can't address through looking at models around building resiliency, building positive self-image, building strong supports around mental health as well as physical health. So Medical Home Development Group, we realize that most of the things that affect health fall outside the doctor's office, just as I've described. 40% social determinants of health, which are those same things that are covered through the ACEs model, as well as 30% health behaviors, 10% environment, the water we drink, the air we breathe, the food we eat, and then clinical care is only 20%. So to that end, we realize the need for interconnectedness between healthcare and all the other factors outside the clinical space. And to that end, I'll start on the left. We're a patient-centered medical home, and so we enable care to be accessed easily, as I've described before, but specifically around opioid use disorder, doing it in a clinical setting where primary care is provided allows the stigma of going to a methadone clinic or going to somewhere where you know that people are being treated for opioids. That all goes off the table. So it's an environment in which people can feel supported immediately when they walk in the door, and they don't feel stigmatized for looking for help. And then we do comprehensive assessments that involve looking at the social determinants of health, mental health, use of substances, etc., to be able to provide customized care to individuals. And we also, in that process, try to look at those factors that promote resiliency that people already have working in their lives to be able to incorporate it into those care plans. And we also work to improve engagement, health literacy, people's sense of empowerment when it comes to their health. We got a grant from the Sibley Foundation in conjunction with Leadership Council for Healthy Communities to do exactly that. And Ambrose was a great speaker for us in that endeavor. And then we integrate services across the board. So we talked about the primary care and the multi-specialty and the office-based buprenorphine, but we also have social workers embedded in our practice so that when we do that, execute that customized care plan, we have social workers who can work hand in hand with us to help link individuals to resources and other community services. And we realize, just as one of the other earlier panelists said, that when you make those referrals, it's really difficult to get that information back. So we're really trying to use telehealth now to, when somebody comes for a visit, which we have a very high compliance rate, by the way, with visits. About 90% of folks show up for their office-based buprenorphine visits. So we, in a sense, have a captive audience, and we are trying to really make it as much of a one-stop shop as possible. So using telehealth to bring specialists to the patient rather than the patient having to travel to go see them. And then that allows us to know the outcome of what that consultation was so that we can feed it back into the care plan. And then I'm just going to jump over in the interest of time to the community and provider partnerships. It's incredibly difficult when you have a substance use disorder to get the care you need, especially if you're in a methadone clinic, because a lot of times those individuals have to go for methadone every single day. And then if you also need social services, you have to catch a bus across town to take care of that. And if you need primary care, you got to go over here. If you have a specialist visit, you got to go over there. So we're really trying to work with other organizations that take care of individuals with opioid use disorder. So recovery centers, the Psych Institute of Washington, emergency departments in the area, and other community-based organizations to really have what we call the DCOC, the DC Opioid Collaborative that helps to bridge information gaps so we're not working in silos and really make it easy for people to transition from care provider to care provider within that collaborative and promote the idea of co-management as opposed to referral. That gives everybody a stake in that person's health outcomes and them doing well, and promotes the idea that we're all working together to make sure that individuals have positive health outcomes. So I'm going to stop there, and I'm sure there'll be questions afterwards. Thank you.
I don't have slides. I don't have slides. I heard they were optional. So I'm going to have to entertain you with some stories. But the slides you've seen today, I think, really complement a lot of what I'm going to speak about. My name is Marisa Perella. I am the director of the school-based mental health program at Mary Center. And I'll tell you a little bit about how Mary Center got started and why that is still relevant today. And then I'm going to speak a little bit about how our program got started and where we're going. But I'm going to start out by telling you a story, as I promised. Wendy mentioned that we are mothers of 15-year-old boys, and as such, a few months ago, mine asked me if I would take him to the Jay-Z concert. And I said, well, it's on a Wednesday. I don't normally head out late on a Wednesday, but okay, we'll go. And at about 10:45, when I was absolutely exhausted in a thumping Verizon Center, Jay-Z said to the audience, therapy really helped me, and I think there should be a therapist in every school. You may have caught him saying those same words in a Van Jones interview on CNN a month later. So I thought it was worth my night out and worth my exhaustion the next day to be so inspired by the fact that this whole audience was able to hear that, and that this idea that mental health is not a stigmatized approach, that it's not based only in clinics, that it needs to be where our children are. So Mary Center started 30 years ago this year, actually, really responding to a wave of immigrants from Central America who were coming, women who were needing health care, who were needed prenatal care, crossing the border. Many of them, all of them had experienced enormous traumas. And Maria Gomez started the organization as a healthcare organization. And she soon realized that healthcare wasn't enough to support these parents after they gave birth, while they gave birth, and where were they going to go from there? They didn't have resources. So from there, fast forward, she developed the social change model, which is providing a lot of what we've spoken about today: healthcare, social services, and education together in one site under one roof. And that's really how they got started, to meet the needs of these immigrant women. Now, we're still seeing waves of immigrants coming. We see a lot of unaccompanied minors. And I'm going to speak a little bit more today, and we haven't touched so much on that immigrant community, especially what I call kind of an invisible community, the undocumented community, that doesn't always get captured in the statistics that we show. They don't get captured in percentage of students who receive TANF, percentage of students who receive SNAP because they don't qualify. Several years ago, school social workers were reaching out to Mary Center Behavioral Health Department asking if we would accept referrals for students who needed additional mental health supports. Now, Mary Center has always been known for providing medical care and dental care and all kinds of social services, with a small behavioral health department as well, and education. So many of the families whose students attended these schools were very familiar with Mary Center, and they knew these immigrant families trusted the services because they're trauma-informed, they understand the special, unique needs of the immigrant community, and they knew that it would be a safe space to access care. So they asked us to come into their school to provide the services. Why? Because our families really weren't able to get their children to a behavioral health intervention every week. So imagine if you have 3 children like I do, and you have to go to the dentist twice a year, and the doctor, and then when they get sick, and how many days you have to take off from work. And that sounds really burdensome, doesn't it? But if you're a mother of 3 or 4 children, and you're a single mother, because maybe your husband is still in your home country, or he's been deported, or he works 3 jobs, it's really hard to get your child to a full episode of behavioral health care, because that requires once, maybe twice a week. It requires your input, and it requires some time. So the schools asked us to come to them because the referrals they were making just weren't sticking. They weren't sticking. So they cleared out an office. When I say office, I mean a janitor's closet or an extra storage closet that they cleared out, and we hired and trained in our approach, in our integrated approach to mental health care and culturally competent care, a few clinicians to go out and spend time in the schools. And when you place a clinician in a school that understands the community and they start to work within the context of the school community, the social workers, the principals, the parents, and they start to see students, guess what happens? If you build it, they will come. And the students were knocking down the doors of the clinicians wanting support. So we had really removed the access barrier to care and really, in many ways, reduced the stigma of accessing care as well. So they didn't necessarily feel like they were receiving mental health care. They felt like they were going to that trusted provider, that staff person at their school that walks through the cafeteria or maybe passes by their classroom and knows their teacher. And from there, the program really grew to be in currently 19 schools. The concept of putting a behavioral health clinician in a school is not a new one. I think what we found through our program was that it didn't really stop at just the behavioral health service. And I love the idea of talking about building community resilience in an interdisciplinary way, because it's not just about the service, it's really about the relationships. And that's really, I think, what we're talking about today is how providers, how communities build relationships with each other, with community entities, and how we're going to make systems work together to benefit our children. So what we realized when we built relationships in our schools with our students and with the parents is that then the schools wanted more. And these schools are schools who really, truly want to do the best for their students and are doing an amazing job, but needed extra support. When you have a school with probably 90+% of students having more than 3 or 4 ACEs, the needs are, it's very challenging to educate them, and you need supports. So from there, we moved on to providing other services. So when at the beginning of a school year, for example, in one school, when there was a large influx of unaccompanied minors who didn't speak English, the English as a Language Learners Program became very overwhelmed by what to do with these students. They were struggling with many different issues. Their sponsors maybe weren't enrolling them in healthcare. They didn't know where to find a dentist. They didn't have a secure home to live in. They didn't have, they wanted to get jobs. They wanted to get an education. So we've developed groups for those students where we educate those students around how to find services by bringing in service providers and connectors to the community support workers. And then through those groups, getting to know those students, they have been able to actually assist other new students to come into the school. So it's really a peer, sort of a peer support. They really understand what that's like to be a newcomer student, and so they're helping other students. In another school during the elections, when there was a significant amount of, I would say, students not fully understanding some of the backlash against the immigrant community, so using language that felt very bullying. This was happening in a second grade classroom. So because we were embedded into the school and had relationships and understood where our immigrant community was coming from, we were able to go into classrooms and provide workshops for the students, really educating them about where are some of the countries that your peers are coming from, teaching them about their languages and culture and what it meant to be documented or not documented. Those are really hard conversations to have, but we found that after we had them, the bullying really decreased and there was much more acceptance among the children when we were able to educate them. I don't want to talk too much about how we're moving forward in the city, and sometimes we talk about, it feels very dire, how much need is happening in the schools, but I do want to wait for the next panel who's going to talk about where we are going in the city, and there have been amazing movements with programs like Mary Center, the Department of Behavioral Health, Matt Beal's group, to be in the schools accessing children there and providing services. And I'll let them speak to that for the interest of time.
Thank you, and thank you for inviting me to be on the panel. So my name is Ambrose Lane Jr. I chair the Health Alliance Network here in Washington, D.C. We do work in Ward 7 and in Ward 5. Ward 7 is where we started doing our work, and we basically do 4 things, and I'm going to explain those 4 things real quickly before I get into the discussion. So the first thing that we do is convene. We are a convening organization, and we convene a whole wide range of stakeholders in health, from managed care organizations to hospitals. We've had the Attorney General speak at our meeting. We've had council members speak at our meeting. But we also have community residents, mothers that also attend our meetings. And we would conduct our meetings to inform people much in the way that we're doing a town hall right now. So the type of things and the type of subjects that we are talking about, we talk about in the community with both professionals and non-professionals. You know, I've came to know some that are in this room that have been to my meetings. And it's all about health. It's all about advancing health. We have a sister organization in Ward 8 called the Ward 8 Health Council. They are also a convener. And they convene pretty much the same way that we convene in Ward 7 and in Ward 5. And the second thing that we do is that through those convenings, we create collaborations. And so we create the atmosphere through which, whether or not it's a managed care organization, whether or not it's a hospital, we'll partner with organizations that are in the community or people that are in the community to be able to do programs together. And we've had at least 7 such collaborations that we were not in the middle of at all, to my chagrin for that. The third thing that we do is advocacy, and we're very serious about our advocacy. Our advocacy is on issues about policy, and we advocate to the lawmakers, to the legislators. So we have something called Health Advocacy Day every year, where we visit the DC Council, and we bring people, experts, as well as community residents to talk about health issues to those council members. And, you know, I've had Matt Beal at some time. I've had Dr. El Bayumi. I've had Dr. Clark. I think, Dr. Clark, you came one time. Dr. Clark came one time. Just want to make sure my memory is working. And we talk about policy, or we talk about programs, or we talk about initiatives or ideas to the Committee on Health, specifically on the council, so that these ideas can percolate and resonate with our council members, because when it comes down to it, some of the things that we're talking about really have to be legislated to become concrete in our communities. We also work on legislation. So recently, we contributed to legislation on early childhood development with the council chair on the Committee on Health, and we worked with Lee and with Matt on that legislation. So it's something else that we do. And then the last thing that we do is programs. So we initiate and create and develop programs, but we also work with our partners to put programs in our communities that the community members have access to. So one such example would be the American Diabetes Association. We have done their Diabetes Ambassador Program. Another example would be the Department of Behavioral Health. We do youth mental health first aid. These are offered free to members of the community. So this is what we do. Some housekeeping notes before I get into the real meat of what I'm going to say. I've been seeing a green building community resilience notebook. Is Wendy in the house? Where's Wendy? I don't have mine. Look, I was at a meeting with Lee last week, and we raved about the red notebook that we got while we were in Dallas, Texas. So the Dallas, Texas contingent here. Okay, so do you remember the red notebook that was given to us by the hospital? It was a fantastic, we just talked about how we still use it, I need my green notebook. I'm just gonna let you know, Wendy. All right. Second, I'm sorry that I can't get up. I twisted my ankle chasing my 4-year-old. I was down at the tidal basin looking at the cherry blossoms. I had a flashback that I was 25 years old. Started chasing it. It could have been a flashback that I was 30 years old. I don't know. The operative word is flashback, and twisted my ankle. Yeah, I told Bill he left the scene of the crime, and he was last spotted at his grandmother's house and then at school. And so I'm sorry that I couldn't stand up. And so I wanted to relate a personal story as we talk about resilience and getting into building community resilience, and more specifically, the pair of ACEs. So a number of years ago, in 2010, my father passed away. And it was extremely difficult because I could not process that grief. Now, my father is a luminary. He's been in the District of Columbia. He's been on radio for 35 years. He's done a number of different things. He worked with Hubert Humphrey. He worked with Jimmy Carter. He was a luminary. And I'm a junior. So without getting into what that means, so he passed away. And I didn't know how to process that grief. And I became very angry, an angry person, because I didn't know how to process that grief. And that had ripple effects. That anger had ripple effects. It had ripple effects in my family. It was a contributing factor to my divorce. And I say that to say I had no idea how angry I was. I mean, I wasn't, crashing things down or burning. I was just an angry person. And I spoke to my daughter, I guess it was about 2 months ago. And she related to me what I was like during the period that I was angry. And she relayed a story to me, and the story had me in tears. I was just blubber, and didn't realize what she experienced through my grief and anger. And so I'm saying that to say that as we talk about building community resilience, we're really talking about building it one person at a time. Let me say that again, about building it one person at a time. Because you can't build community resilience without building family resilience. You can't build family resilience without building personal resilience. You just can't do it. And so these definitions become very, very important as we do our work. Part of the work that I do with ESON and with Matt and with Bill and with Georgetown and George Washington University is that I'm also a connector. One of the things that I have assisted in is connecting them to these lawmakers, connecting them to the councilman, connecting them to the attorney general, and creating, again, an atmosphere where their expertise can be endowed upon the lawmakers or those that have the ability to change things. And I'm very proud of that, very, very proud of that work. I mean, we've come a long way in a very short period of time in terms of how the council sees the ESON project, how the council sees the work that we're doing in BCR. So there are two components, and it relates to my work. So the two components are the pair of ACEs, the adverse childhood experiences, and then the adverse community environments. So these are the couple of things that I've learned through this process. I've learned on the adverse childhood experiences that it can happen to anyone, any race, any income level, any part of the United States. I learned that through Bill. And I didn't know that at first. And it broadened my mind in the way that I think about adverse childhood experiences. But then there is a flip side. I shouldn't even say flip side. There is another side, which is the adverse community environments. So even though any race, any child, any adult can experience an adverse childhood experience, they don't necessarily live in a condition where there is an adverse community environment. Those are two different things. And I'm working in an area of the city where there are both, okay? And I just want to point out a couple of things about statistics. Statistics can be extremely deceiving, and I'm just gonna point that out, how they can be extremely deceiving. So in the district, when there are economic development drivers, so developers come and they build buildings in different parts of the city, leaving alone Ward 7, leaving alone parts of Ward 8. But they use a tool, and that tool is called AMI. Anybody familiar with that tool? Area median income. Area median income is a tool that developers use to determine what type of housing that they're going to build and whether or not that housing is quote unquote affordable housing or low income housing. and they use a percentage of AMI to determine how they build buildings. And this is, I'm gonna point this out because we have to really dig into the meat of the work that we're doing statistically as well. So they use AMI, and right now AMI, area median income in DC, is $119,000. So if they're building what's called affordable housing at 30% or more of AMI, but they're building it in a community whose median income is only $40,000, then the vast majority of those residents cannot afford to live in what is called affordable housing. And that is one of the things that we are seriously experiencing in the District of Columbia. It leads directly, it's a direct line to the gentrification and the pushing out of communities in Washington, D.C. We saw on the screen where communities are moving into the suburbs and things of that nature. And why are those statistics important? I'm gonna just share a couple of, Wendy went through some of the disparities that exist in the District of Columbia. And I'm gonna just point out a few. You have an area of the District of Columbia called Palisades. It's up near Foxhall. It's near Georgetown University. The number of single female-headed households in that area of Washington, D.C. is 7%. The number of children or percentage of children in poverty in that area of the city is 1%. If you, by contrast, come to right here, or historic Anacostia, or Deanwood in Ward 7, the number of children in poverty ranges from 60 to 70% in the same city, along the same line, metro line. The number of female single-headed households in Deanwood is 77%. In Anacostia, it is 86%. That is the contrast. The other contrast, we talk about median income, but it's really about wealth disparity. So the wealth disparity is something that we're dealing with as well. Well, a typical Caucasian family in the District of Columbia in Ward 3 has an average wealth of over $200,000. The typical family in Ward 7 or Ward 8 in Washington, D.C. has an average wealth of $4,600. So as we are talking about ACEs and adverse community environments and building community resilience, part of the work that I'm doing and getting into more and more and more is really addressing those specific disparities which happen along the social determinants line. These are the disparities more than anything else that are part of the drivers for the adverse community environments, which has a direct impact on ACEs, has a direct impact on mental health, has a direct, and Dr. Clark talked about opioids and DC being fourth highest city. Opioid deaths in the districts are higher than the murder rate, higher than homicides. There are more opioid deaths than there are homicides. But there are more deaths due from diabetes than homicides, cancer, and HIV combined. So these are the things that represent the challenges that we are facing here in the District of Columbia. District of Columbia is said to be the second healthiest city in the district, but yet we have these disparities not amongst a small neighborhood, amongst more than 140,000 of 700,000 residents. More than 140,000. If you include Ward 5, you're talking about almost 200,000 residents. So we have to just be careful about statistics to be able to drill down into the communities that we are trying to serve as we build community resilience, as we build individual resilience, as we build communities and individuals and families. And so, I didn't come and say what I had prepared to say. Okay, it was on my heart. And as I saw the presentations, I just wanted people to know where I live, because I live in Ward 7. I live in the area that I am trying trying to fight like hell. And as a result of learning from people like Bill, learning from this experience with BCR, I actually decided to put my hat in the ring and run for the DC Council so that I can bring these policies to the conversation, because these policies that we're talking about now are not part of the conversation in our politics, and I'm bringing it to our politics. This is the conversation that all of our politicians should at least have an understanding about. So I just wanted to leave that.
Going a little too far.
I'm gone. I got you. So that's my story, and I'm sticking to it.
Thank you. I do want to just acknowledge and thank Ms. Kim Harrison is here from our thank you. There she is with her sparkly Obama hat on from a council member Trayon White's office, who is Ward 8, and we are in Ward 8 for those who are not from DC. Thank you.
So one of the things that really struck me about this whole panel is, the delivery of services to an area that has dire need. And one of the things that I think Dr. Clark that really struck me, as well as you, Marisa, is this, and you, Ambrose, is this theme around collaboration. Dr. Clark, you spoke about the DCOC and the collaboration there, as well as Marisa. Obviously you're working across healthcare and schools, and Ambrose, you're talking about collaborating with community and bringing in individuals to talk about various resources. But I want to, Dr. Clark and Marisa, we have seen across the country, there are real barriers to the types of collaboration that you're able to pull off here. And I think it would be really helpful, since we have both community as well as some of our leaders in the room, to talk a little bit about those real barriers that are getting in the way for us to being even more effective.
There certainly are barriers. I mean, one I think of right off the bat is just the way funding is allocated. Our funding is siloed. So funding happens through healthcare. So this is how healthcare is funded. There's education dollars. There's social service dollars. So when we're talking about collaboration, and especially when we're talking about a trauma-informed approach, when the success of a program that involves a mental health practitioner, an educator, a principal, a parent, involves having the same trauma-informed approach, which really means empowerment, developing relationships, developing a sense of safety in a school. When all of those people must work together to have that same approach to deliver a service to that child. And that can be very, very challenging when we're all trying to check our boxes as to what we have to do to get that grant or apply for that funding or bill that service. And so one of your video today actually spoke to that about funding and how the funding really has to catch up with the innovation.
Yeah, I would echo that. When you're talking about opioid use disorder, you're talking about physical health consequences, the fact that at least 50% of individuals with opioid use disorder have also a mental health disorder. And then to Ambrose's point about diabetes, the folks, one of the slides I showed that their individuals in DC most affected are between the ages of 45 and 64. That's when all the chronic diseases show up. And so there are a lot of statistics and studies that show if you have coexisting mental health and substance use and you have a chronic disease, you have a much higher rate of healthcare utilization, emergency department visits, hospital visits, etc. So within opioid use disorder, you have the need to work with the Department of Health, the Department of Behavioral Health, and the Department of Healthcare Finance. And because those governmental agencies sometimes function in silos, it's very difficult to really have a unified policy going across the board. So I would say that that's one challenge, one barrier, is just the way that, for example, I mentioned people having to go across town to go to a core service agency to get mental health services, or the fact that the residential recovery services are in a silo all by themselves, funded separately. And until we actually went and inquired and started talking to them, and I take my hat off to our engagement officer who did that, there was really no communication. So now we are able to say, hey, we can provide primary care on site at the residential treatment facility, or our F Street location, which seems odd given our mission, but it's really not that odd, because in the same building is a methadone clinic, and so we're providing primary care to those individuals between the hours of 6 a.m. and noon when the clinic is open. So we're trying to reach out and do this work, but because the alignment within the government agencies is so siloed and the funding that flows is siloed, it's definitely a challenge.
One of the things about BCR that we talk about, and you heard me speak to this, is that it's good to focus on the deficiencies so that we know the problem that we're trying to solve. But it's also most important for us to think about what's already in place. So clearly there's something that is in place that's working. And what really impressed me, what you said, Dr. Clark, with regard to, I think you said 90% engagement rate with regard to your patients, that is impressive. I mean, working with our healthcare partners across the country, I think there are a number of practices that would love to have that number. So clearly something is working, whether it's just strictly with the medical home development group or with your casket, your array of partners. So can you speak to what is that, what's attributing to that, that success rate, but also how we might build off of something like that?
So yeah, I mean, I think one, and to be specific, that's among the individuals that we're treating for opioid use disorder. So one issue, like I said, is it's a destigmatized environment, so people feel comfortable coming, number one. Number two, I think, is the cultural competency of our providers. Our lead provider has been doing this for 17 years, and he has then been able, we use what's called a hub and spoke model for our other providers who've gotten certified to provide buprenorphine, for him to mentor them and show them how to do this in a culturally competent way. And then, you know, thirdly, I think it's all the other wraparound services, and people realize that because we're putting all these things in place and trying to make it easy for them, that we're trying to meet them halfway. And I think individuals appreciate being respected and you know, working with them to achieve their goals and their health goals. So I think it's that combination. And another statistic from our practice I think is important to share. So if you treat somebody just with detox, as I mentioned, just going cold turkey, there's only a 10% success rate, retention and care at 1 year. Whereas when you use office-based treatment and the way that we've been doing it, we actually have a 78% retention rate at 1 year in treatment, and at a year and a half, 70%. So I think that also speaks as well to the work that we're doing.
So I don't want to monopolize here, but I definitely want to take some questions or some comments from the audience, if anyone. Yes. Make sure you introduce yourself.
Hi, I'm Nick Lang. I'm part of the Root Causes Project. Given that opioid use is not just stigmatized but criminalized, what do you think the impact is in terms of both difficulty in care as well as creating a more competitive environment between police and the community they serve?
So one of our goals is to really be able to work with the criminal justice system, because I would say, and this is anecdotal, we have not done a survey, but to speak to that criminalization aspect, in the individuals that I interviewed for one of the contract relationships we have with with Department of Healthcare Finance called Health Homes 2, I would say at least 75% of the individuals we care for with opioid use disorder have had some sort of interaction or stay in the criminal justice system. And that definitely speaks to their ability to then be successful returning citizens. And also at the same time, it puts them behind the 8 ball in terms of, if you're not able to get a job, to then be able to live successfully with your addiction. and be in recovery. And so one of the things we've done is really to try to work with peer navigators who have walked that same walk to be able to help individuals navigate within the community. I'm not sure if I answered the second part of your question, though. Maybe you could repeat it.
The second part, and maybe it's more for Mr. Lane, is whether or not that has an impact in terms of creating a competitive environment between police and the communities they serve, especially given that a lot of young men go to prison and are no longer there for the families.
I wouldn't say that opioids are the reason for that. I would say that it's across the board, the criminalization of multiple kinds of illegal substances. You know, and it's not just opioids, it's really across the board. And I think to the degree that we can really look at how we can advocate to change policy in terms of the criminalization of these substances and how individuals who use are treated in the criminal justice system, I think we will really make a huge dent in that. So I'll give
Yeah, so a few years ago, marijuana was legalized in the District of Columbia. And it was legalized partially, the partial argument for legalization was based on a social justice issue, that it would reduce the number of arrests of African Americans, particularly African American males. So it was legalized, and we found out at the end of 2017 that the number of arrests of African Americans for violations of what is now legal marijuana are more than what they were prior to the legalization. They attribute this to the lack of information in the community about the laws surrounding legalization. But we know, those that are in the community know that that's not true. And so why is it that there are more arrests of African Americans even after legalization? The other thing, and so how that speaks to the opioid crisis in particular. And again, I come back to these adverse community environments. So we're in Ward 8 right now. Ward 8 has any given month between 3,500 and 4,500 unemployed people. And those are the ones that are technically unemployed. So those do not include those persons that no longer apply for jobs. So we know that that number is greater. We know that the youth unemployment rate is anywhere between 35 and 50%. And the propensity of those that are unemployed to move into illicit activity and illicit drugs is very high, especially when it is chronic unemployment. And so all of these things are circular in terms of this issue. So with regards to the criminalization of opioids, we also have to look at how opioids are actually, and I don't know the answers to these questions, but how opioids actually come into the District of Columbia. It's not simply that they are prescribed and then they're passed. So they're able to, people can get them online. There are a number of different ways in which opioids come into the District of Columbia and into Ward 7 and 8, but not just Ward 7 and 8, but other parts of the district as well. And that's something that we need to look at in terms of how that is happening and the effects that it has.
Thank you, Ambrose. And on demand here. So you ask and I deliver. There you go. So we're running late here on time, but I want to give a standing O to our panel here, who hopefully, if you have some additional questions, they'll be able to provide some answers for you. And I want to move really quickly into our next panel, our last panel, Local Policy Change to Build Community Resilience. And I think that's perfect because both Ambrose and Dr. Clark, as well as Marisa, spoke about the need for policy change. So I'd like to invite Dr. Olga Price from George Washington University up to the front, who is the director for the Center for Health and Healthcare in Schools at GW, Milken Institute School of Public Health, as well as an associate professor in the Department of Prevention and Community Health at the university. You know, it's really important for us to know all of the different resources and how I think really the university is working very hard to change the trajectory and influence the trajectory as far as public health is concerned here in the district. And one of the things it's really important to think about what Dr. Price has been doing, because at the center, she advises government officials as well as leaders in education systems and healthcare institutions on how to provide integrated, cost-effective, and high-quality health programs in schools, train professionals in best practices in school health, and inform policymakers and the public on alternative approaches in school-based healthcare. Dr. Price was also the founding director of the DC School Mental Health Program and helped launch comprehensive school-based mental health programs in more than 30 public, charter, and DC public schools in over six years. And she's also the co-chair of, most recently, the co-chair of the DC Task Force on School Mental Health. So we definitely have a boss lady in the room here.
And you know what, Sarah, maybe, do you want to stay there? Do you want to just sit and then I'll introduce you? Okay. So, hi, I'm going to stand here. Not that I want to be far from you, but in an effort, can you hear me at all? Okay. How's that? All right. All right. In an effort to try to stay on track, I did write some notes because otherwise I know a lot of you, and I just feel like I'll just go on. So I'm going to try to keep myself covered here. I just want to also let you know that we have a really great addition to our panel, a friend and colleague, Osa, who will, if you see someone running from the back and joining the panel, he's supposed to do that. So it's okay. He just unfortunately had a driver who got lost. So I'm going to, before I even kind of go and introduce Sarah and Osa and their incredible qualifications, I want to speak a little bit to you about, and it's interesting that I'm being asked to moderate a policy panel because I'm really a clinical psychologist by training. I'm a trained provider, trained in school mental health, and I don't know how many others of you have a clinical or a social work or any other non-policy related training, but we didn't have policy training at all. So this was a very scary, I know when I started my career, anything that even started to sound like policy, I ran in the other direction. So I just felt like I wasn't trained and qualified to know what to do. Now, ironically, I feel like everything I do has a policy implication, and and it took a long time to learn some of these things, but part of what I think we're going to be, really try to do is to leave you with a couple nuggets, not rocket science, things you likely already know, but a way that I think in our experiences we've learned to distill to these anchors that help the work move forward, so that when it gets very complex, when it gets really hot, when it's not clear the path, we can hang on to these anchors as we move forward. So I'm going to start kind of from the perspective of, that we really have experience and incredible opportunity, again, as a behavioral health provider and someone who advocates for the behavioral health needs of young people, this increased dialogue, a real greater appreciation of the science behind trauma, the brain science, how social determinants and the conditions in which we live, learn, work, and play really ignite these stress responses that impact health, impact behavior, and many other outcomes. But something that we often, as again, I'm going to speak to us from the public health side, that we often don't realize the same determinants for education, the same determinants that often will determine inequities in educational attainment. And again, for those of us who understand the levers that really set pathways for improved outcomes, education is one of the best predictors of adult health and adult economic outcomes, right? And so it's important that we recognize that we don't, again, separate those. Behavioral health needs in this city, as many of our previous panelists have alluded to, remains a very big concern. This is something that's not just a concern for government officials in DC or leaders, but for families and residents as well. And it's led to a number of things that I want to sort of set a little bit of a quick trajectory around what we've done in a policy arena that has set us up for what I hope to be a really exciting move forward. There are, as we know, a lot of things that contribute to the high unmet mental health needs in many cities and in rural areas, but in DC, including, as we know, acute and chronic exposure to violence and concentrated poverty, poor access to coordinated care, things like few pediatric mental health providers. You know that if you're in DC and you can't get an appointment with a child psychiatrist, you're not going to be able to get one anywhere, because we have a very high concentration of professionals, and you could be a person, even those with resources, and can't often get an appointment with a child psychiatrist, is one example of where we have systemically provider shortages that you can imagine are impacting. Then it really does matter often where you live, and to the degree to which you might even be able to access those specialists. So these are the kinds of things that drive often the existence of the kinds of mental health problems and undermine success. I'll start from 2012, which is when a really important set of policy activities occurred in DC. The South Capitol Street Memorial Act was passed in 2012 in DC, and that was championed by a number of people, particularly in city council. It was in response to a fatal shooting that killed 4 young people 2 years prior. And I won't go into all the details, but it really signaled a doubling down of the city's commitment to address the systemic issues related to youth violence and to make accessible what at the time, even with long-standing investments in DC on improving access to mental health care, through, for example, the kinds of programs that I had the pleasure to help launch, like the School Mental Health Program and Maurice's program, that really are examples of public mental health approaches to addressing behavioral health needs. But it said we've got to do more because there are still incredible gaps. And it required an expansion of what already was a very robust school mental health program that was in 65 plus public schools. So when I left the Department of Behavioral Health, we were in roughly 30 schools, and it grew into 65, almost 70 schools by the time this act was passed. So it wasn't that there wasn't growth and that there wasn't continued investment on the part of the city and continued sort of capacity building, but it still wasn't enough. And as Marisa said, there were still populations, particularly vulnerable populations, that were inadvertently being ignored. So the agency that really was in charge of implementing the citywide program, the Department of Behavioral Health, was mandated to figure out how they were going to be able to demonstrate that all children in DC, regardless of where they were, what ward, would have, quote, access to the necessary behavioral health programs and services in schools. The idea that we had already learned from many, many years of investment in DC that, and as Dr. Clark had mentioned, that the idea that you bring the services to those who need them was a very effective and has been shown in the literature to be very effective. I asked them to keep this up because it really applies to a lot of what our work and is a really interesting framing for a lot of the policy directions in DC. But because we know that that co-location model, but not just providing specialists, which is really making those available and folks who have particular training available in schools, but integrating those professionals within the school's operations and in there, and so that they could influence not just the availability of clinical care, but also that they could be there to be coaching, consulting with teachers and engaging with families and linking to other specialty care and really being one of the many gatekeepers that could be supportive in a school. So in response, the leaders created a plan that was submitted in May of this year. And although there were some really important critical elements that we thought very good, there were some problematic areas that we thought were critical gaps that we thought were really going to undermine progress and the progress that had been made. So this is where DC City Council, and we have someone who's going to be coming hopefully any moment, who works very closely with a city council member and the Committee on Health. And at that point, the Joint Committees on Health and Education had decided to hold a public oversight roundtable in June. And I decided I would testify. No one had reached out to me. This is a program I believed very strongly in and had long ties to, and decided that I felt an obligation as a clinician, as an administrator, as a researcher, to share what I knew about what I thought were some of the gaps in the plan and ways that I thought it could be improved. So part of my testimony argued that the long-term solution to supporting the social and emotional and behavioral development of all the young people in DC really required a focus on more than just one agency's actions, not just picking on the Department of Behavioral Health and what they needed to do, but instead on how we could build strong cross-sector, system-wide approaches across all child-serving agencies. At a minimum, we had to do that if we were going to get to the next level. And so it involved and implicated not just the schools, not just the mental health agencies and the providers, but also Medicaid and other programs and sectors that were providing prevention services. Those, for example, who were working with kids who were wards of the state. I mean, so we really implicated many, many systems. In response to being a witness, so no good deed goes unpunished, is that DC Council had decided, because of the overwhelming response of the witnesses who had come to testify publicly, that they would propose creating a task force. So the School-Based Behavioral Health Comprehensive Plan Amendment Act of 2017, which was a legislation that formed a task force, was passed by City Council in June, signed into law by Mayor Bowser in July, and became effective in October of last year. So things moved fairly quickly. The task force was comprised of representatives from a robust cross-section of stakeholders, including a lot of folks that actually are in the room, and we met a lot for many hours between November and March to make recommendations of how we were going to improve the plan. And as I guess an acknowledgement of the kind of the history and the subject matter expertise that I brought, I was asked to co-chair that task force. Among the numerous recommendations that we created and that we offered was that there be an oversight body, which now does exist, and again is very aptly coordinated by the Department of Behavioral Health, called the Coordinating Council. It includes current task force members, and importantly, in addition to a number of recommendations that again ended up coming from much of the collective expertise of this body of stakeholders, leaders, parents, was that there be a budget ask of $3 million for the coming fiscal year to focus not just on co-locating and providing and identifying more providers that were going to be able to go into schools, but to additionally really focus on building community capacity and on school capacity and on aligning
Olga,
policies and procedures.
can you talk into the microphone?
I'm not
We've got
talking
live
into the
stream.
microphone.
We've got Facebook live
I
stream.
have no
going on.
idea. I wasn't
can't
talking
hear
in the
you.
microphone. Okay. All right. How's that? Any better? Okay, great. So I just feel like it's in my face. I don't know how to bring this down. All right. So what we so although I would say it's too early to call what the task force was able to do a win, I do thank you for it really, thank you, sir. I don't have see, you ask for help, ask and you shall receive support. All right, good example. Thank you. So although I think it's a little early to call it, you know, a definite win, it really signaled great progress and looks to align efforts across the city and to coordinate the distribution of resources, which many would say has not been equitably distributed across all areas of the city, right, in all public schools. Similar to Ethan, which I don't know if you were going to say this in your remarks, I don't think so, or Lee or Matt, but that I wanted to say a couple of words about public-private partnerships. Hello, my friend. And the role of philanthropy in some of your work potentially, and in what it did in DC. There we again are very fortunate to have private funders and philanthropists who are very dedicated to trying to improve well-being in DC in various ways. Maybe Sarah could say something about who some of your private partners are. For the work in school mental health, one partner that I want to mention is the Bainham Family Foundation, who is a local funder that has had a long-standing commitment to improving the lives of families in Wards 7 and 8 in particular, and have invested millions of dollars over the years. And in particular, though, decided to launch an initiative. I will disclose that my center, still not, huh?
Sorry, this one might be better.
Okay, I'll do this. That's all right. I'm sorry. So that includes investments in trying to improve the social emotional
outcomes of young people, particularly in Ward 7 and 8. And part of what that project and initiative was going to include is identifying 4 schools in Ward 7 and 8 and being able to do a demonstration project to really support schools in figuring out how to implement what we consider comprehensive school mental health best practices, okay? And really how to strengthen their multi-tiered system of supports because of, again, what we know about how critically important it is, the role that schools play in supporting kids and families' well-being, not just their academic performance, but certainly many other outcomes. And because we didn't want to launch an initiative like this in isolation from a lot of other things that are happening in DC, so there's a couple things about DC for those of you who aren't necessarily from here. Obviously, lots of things going on in what really is a very concentrated area, and many of us end up knowing each other, right? So that's good, I think, in many ways, especially as it relates to some things we'll probably talk about in terms of policy implications. But one of the things is, even though we have a lot of, I don't know how many universities, again, not a very large square, maybe you know this, Osa, but we still are very disconnected, and we still end up being very siloed, which is really unfortunate. And it was something that the foundation felt very strongly that we didn't want to move forward with an investment they were going to do that was going to, again, be in isolation of other practice, policy, and program innovations that were going on across the city. And so one way that we're going to try to tackle that is creating a district-wide learning, kind of a stakeholder learning community that would, again, involve many of the same people that you probably saw on these panels, that would really offer their thoughts and thinking about how to improve coordination of services and to develop system responses. So having been a couple more points I just want to make before I turn it over and introduce my esteemed colleagues. Having been, as director of the center, a technical assistance provider for a lot of different communities, so I'm lucky to be doing this work now in DC, which I feel very passionately about. But we've provided this kind of technical support to districts and departments of health and even philanthropy in other areas across the United States. And one of the biggest struggles that we've heard, even though in those initiatives we've been able to help those communities seed innovations and test models and look at the best ways to implement school health programs and practices, is that as soon as that seed support goes away, so does much of that innovation, right? And that's too common a scenario for many communities. And we wanted to think about what could we offer and how could we be thinking about how to tackle the issue of sustainability from our vantage point and from thinking about it from a public health lens. And so one of the ways that we did that is by creating what we're calling an action guide. And we have a one-pager on the table as you walked in. Maybe when you walk out, you can grab it. And essentially, the point of this free online resource is that we wanted to create practical steps that people could think about, that you would then be able to employ in your own context to think about, well, how do I move from point A to point B? Because we are no longer in a position, I think, as school health advocates, where we have to convince educators that these are very complex issues and that the social determinants are similar between health and education, and that if a kid isn't healthy, they can't learn. We're like not at a point, thankfully, where we have to make those kind of arguments very much anymore. But it still doesn't leave us with pathways of what do we do about that. So, okay, I'm a school or a school district, and I see every one of those kids who comes through the door or who's absent because they're not coming through the door. What is it that I can do as a school district? I am not a mental health provider. I'm not a social service agency. So this is where we really try to talk about the importance of these cross-sector collaborations and partners. Issues of, it illuminates critical questions. Who, what, and where, and how, okay? Who is, and in this case, in terms of policy, who is knowledgeable about the policymaking and budget setting processes that are critical to advancing what it is you're trying to do in your communities? What policies and procedures specifically do you think are the ones that are necessary to advance your initiative? And while funding, I will absolutely agree, is very critical and was mentioned in the previous panel, is really important to sustainability, it isn't the only way to ensure implementation or to sustain prevention or cross-sector collaboration. It's often the easiest one that we go to. It's the one that we always feel like is the major policy barrier, but there are often so many others that we can identify and tackle first that could get us to a point where we could have graded blended funding opportunities, where we could actually leverage the resources that we have. It's important that we think about not just the policies that might be sort of in your kind of setting your path, such as, for example, bullying policies or Medicaid policies that you might decide as a community you have to tackle in order to make sure that your initiative is going to move forward. But it's also thinking about procedures, which is sort of the, again, not having been trained, and this is where BCR has done an incredible job of putting together toolkits to really try to understand and educate many of us around what this means. But it even includes things like thinking about job descriptions for different agencies that are working for social workers or local mental health providers, and what's included in those scopes of work, and how you can advocate for those changes in order to allow folks to do case management, or the Medicaid policies that you might have to tackle that would allow folks to get reimbursed for things that we know are critical, like consultation, that would allow us to be much more effective at reaching out to families who need those kinds of supports. But you can't keep agencies going if they don't have a way of a revenue stream. And then how the policies impact your initiative, whether you're advancing it or whether it's hindering it. So for example, it's not often just thinking about what's the policy. So I have a Medicaid policy, or I have a bullying prevention policy in the city, but it's really thinking about what's the action I have to consider. Is this a policy that I want to connect to, like the South Capitol bill, that actually provided us an opportunity to push forward and to leverage something as it related to the task force, because we could use it to ignite and as a mandate that had us actually move as a community because it was mandated legislatively? Or is it something where we have to advocate for change because, such as in the plan, where we needed to come together and provide sort of a policy opportunity for saying that we needed to change or adopt the plan in a way that would make more sense for DC? Or is it something that you have to think about standing in the way of because it is fighting, you have to fight it because it's hurting your initiative? So I think I'm going to leave you with 3 lessons learned. One is context matters. So you hopefully have heard of examples from DC and from each other about things that have been successful. But those things have to be translated and customized to what makes sense, obviously, for your communities. The allies that you're going to engage, the resource that you have to identify, where you're going to target your communication, certainly tracking and shaping those policies and legislation. All of that is deeply dependent on your local and your state context. So we have to get comfortable, and if we don't get comfortable, find partners who feel comfortable, who are willing to be in the room with us and constantly consult with us on that. The solutions that work in one location aren't necessarily going to work in multiple locations. Secondly, language matters. Be mindful of the kinds of working in school health. There's a lot of language that gets sort of thrown about, and the labels and the terms, but considering how some of those could really leverage your opportunity. So even though we might have been thinking about youth violence prevention as the frame for the South Capitol bill, the fact that now we have a suicide prevention bill, or that we have a school climate bill, we can shift and figure out how can we hook the principles or the principal actions that we want to this other policy opportunity, even though it's not using the same language. So it's sort of not getting so tied to the label that allows you to sort of not take advantage of those opportunities. But in terms of language, it's also referring to speaking out. Public forums or hearings in order to be acknowledged as an expert. And each of you do bring expertise. And providing that information to folks like OSA who help manage or who lead task forces or commissions or agencies or council members, and being at those tables so that you can help shape some of the final decisions that get made. And then finally, process matters. I say this because often when we consult with communities, they feel that it's a specific program or it's a specific solution that they're looking for. They're looking often, because of desperation, for those magic ideas, for those magic solutions. But it's also about we don't want to shortchange the importance of process or the manner in which we're going to move forward. It's thinking about how we identify those allies, how do we frame the issues at hand, how you build existing rapport and support opportunities. It's about relationship building, it's about decision-making processes, it's about training, it's about capacity building. And those are processes that we have to think about, not necessarily specific programs. So with that, I'm going to turn to my colleagues and friends, quickly introduce them. And
Dr. Price, can I just be the bearer of bad news that we are just 20 minutes between Ben's Chili Bowl and the rep?
Can't we have a few extra minutes?
Yes,
okay.
Absolutely. Absolutely.
Okay. So I'm going to quickly say Sarah Barkley-Hoffman is Assistant Director of the Early Childhood Innovation Network, Program Manager of DC Collaborative for Mental Health and Primary Care, focuses on early childhood and perinatal mental health. So I'm going to also introduce Osa Imadojemu, sorry, Osa, is currently the Deputy Committee Director of the Committee on Health at DC Council. He's responsible for health policy as well as operational and budget oversight of the district's health agencies, particularly Department of Health, Department of Healthcare Finance, Department of Behavioral Health, and Health Benefit Exchange, among others. So obviously a very big charge. I'm going to turn to Sarah and then ask you for 10 minutes and then Osa to wrap us up. Is that okay?
Thank you, Olga. It's great to be here with everyone. So again, as Olga said, I have the distinct pleasure of working with the Early Childhood Innovation Network team. I know my co-directors, Matt and Lee, spoke about that earlier, that was a couple hours ago now. So I'm just going to give, also being mindful of time, but just give a few sentences to reorient folks to that, including if we have some new faces in the audience. So the Early Childhood Innovation Network is a local collaborative of health, education, and community providers, community organizations and leaders, researchers, and advocates, really working to promote resilient families from pregnancy through age 5 in the District of Columbia. EASN really works across sectors to empower adults in that caregiver role, whether that's parents, family members, educators, health providers, to ensure that they have the knowledge, resources, and skills to really improve outcomes and support young children. And again, our work is really grounded in the science that we are very aware of in terms of relationships, both positive and negative, and experiences really profoundly impact young children. And our work is really rooted in community voices and co-creation, multi-generational, and in the science and research, collaborative across a variety of sectors. And really, as we've heard, I think, throughout this day, building on existing resources. And we are working on innovations in obstetrics, prenatal care, pediatric primary care, early learning settings, and other family and child serving settings. And what I want to talk about some is, in addition to some of the innovations that we're working on, we also are really thinking about this policy and systems transformation piece. And we are fairly early into our work, 2 years, but really have been thinking about that since the beginning and have had the pleasure to be working with a lot of others who are doing phenomenal work in DC in this policy space. So I'm going to speak a little bit about that work, as well as a bill that we have been, I believe was referenced earlier, that we've been working on, and then have a few takeaway points. So the Early Childhood Innovation Network is really honored to be a part of the Birth to 3 Policy Alliance. It's a local alliance that's convened and funded by the Bain and Family Foundation. So we're really, really grateful for their vision and support in really prioritizing infants and toddlers and their families in the District of Columbia, and bringing together local children's policy, advocacy, early learning, and health service providers to really think about and actually advance comprehensive and systems-focused solutions to really improve health development, emotional well-being learning of our youngest children, and ensure that their families have the supports that they need. And it really is a very diverse membership: health providers, children's advocates, hospital health systems, FQHCs, high quality early learning providers, family empowerment and engagement organizations. And we are lucky to be able to meet this alliance on a regular basis to have a lot of shared learning. I think we have talked about there often is just so much good work going on, and we sometimes don't know what each other is doing. So having that time and space to be able to come together and learn, and then think about what are those strategic directions, advocacy, policy spaces we want to be going and moving into together as an alliance. And I believe actually Ambrose teed this up for me in terms of this early childhood legislation that we have been able to be working on, the Birth to Three for All DC Act of 2018. Very thankful for the vision and work that Council Member Gray and his staff has been doing to really create and move this forward. So this is a really comprehensive piece of legislation focused on furthering a coordinated system of health, early learning, and family supports for infants and toddlers and their families. It was introduced about a year ago and is really making its way through the process, through the legislative process, which is really exciting. And speak not about every component in detail, since I do know that the three of us are between everyone and dinner at Ben's Chili Bowl. We're, in particular, the Early Childhood Innovation Network has been able to contribute some learning and expertise to one component of the bill in particular, which is a Healthy Steps Pediatric Primary Care demonstration. And as I believe we heard earlier, that is one of the innovations that ESIN is working on and has brought to pediatric primary care clinics here in Ward 8, a model that embeds an early childhood development specialist and family champion within the primary care team and meets with families at well child visits from birth to age 3. And within this legislation, that would expand that out to more clinics in Wards 7 and 8. But there's also just really an incredible array of comprehensive systems focused pieces in this legislation, expanding local funds for home visiting, expanding our early childhood mental health consultation, which is really supporting early learning teachers and their capacity to respond to children who might be exhibiting some behavioral concerns or some challenges in the classroom. Working on expanding our comprehensive resource and referral system for child development and family supports, which is Help Me Grow. And then a lot on the early learning and childcare side of things, some really specific pieces in terms of subsidy rates, so they really cover the cost of care, the true cost of care, and compensation for teachers, developing a competitive lead teacher and associate compensation scale, and really expanding our number of high quality early learning centers here in the district. And over the last year, it's really been a pleasure to work with our fellow Policy Alliance members in terms of our education and advocacy. So being able to hold a briefing for council members, actually really focused on that education piece of the early childhood brain development and science that is really behind and driving all of this work, really that foundational piece, doing those individual meetings again on that education and making sure that all of the council members are aware of this and how critical this is, and being a voice at testimony and getting our other other advocates, family members to be that voice. I think we hear from our staff that's really critical in terms of bringing those folks out to really show our decision makers, our legislators, our policy makers that people are really pushing this. And I think Ambrose actually said this to some of us in Easton some time ago, that the sustainability piece is not just the funding or the policy change, but community members wanting these changes, wanting a different way of doing things, wanting these programs. And so I think when we can demonstrate that our family members, our community members are really saying, this is what I want, and I'm gonna come and tell you this is what I want, is really important. And in terms of some lessons learned and key takeaways, I actually brought something just to help illustrate this. So I have a 6-year-old son and an almost 3-year-old son. And my 6-year-old really likes to make, I don't know if you can tell what this is, paper airplanes. Sometimes my purse is filled with these paper airplanes that he makes in the house, or frankly, wherever we go. So when I was thinking about these key lessons, it sort of made me think about this, or perhaps the other way around, since I'm looking at these airplanes all the time in my life. But and actually, Dr. Chosky talked about this earlier. Aim high, be bold. And I've really appreciated the vision and boldness of this legislation. I also recognize that we operate in different communities, in different political contexts. And so I'm not suggesting that you go and propose something that you know is just totally wild and off base and will have no traction. Not that, but I think we can tend to be really pragmatic and really realistic, which is good, but what else deserves us to really aim high and be bold in this work? And so just think about your context and aim that airplane high. My son wrote United on here, so we could think about United Airlines. I think a really critical piece of this in terms of our success, at least thus far, has been this cross-sector coming together, and we each have our piece that we are contributing, our area of expertise, but we are united in our ultimate goals and voice. And I think sometimes these things can be derailed when there are factions or people segmenting off, particularly if it's a lengthy process, but really being united in that ultimate goal. And if that means things need to be worked out or whatnot, but I think that is a key piece that I have really seen in terms of being able to move this work forward and be successful. And then my last 2 points, I had a little harder time thinking about the paper airplane, but I think I got there. So relationships, this may be simple, but right, we're talking about relationships and having really strong positive relationships as a buffer. We know that is so critical in terms of buffers at the individual level, the family level, the community level, and thinking about how that works in our programs and our practice changes. And I just think it's so critical to remember that those relationships are also what is going to move the policy work forward and the advocacy work forward. It's a thread through all of this. And whether it's an existing relationship, forging a new relationship, and that's something that everyone can do, whether you're a parent or a community, a concerned, caring community member, a practitioner, provider, and that is really going to be critical. And also thinking about serving as an educator. I think this process and what Eason has been working with a lot of other folks over the last 2 years in these policy spaces and others have said, again, I think throughout this day, that there still is a lot of education to be done with decision makers at all levels, and that is really critical. And don't underestimate the importance of that, and just what a critical piece that is. So in terms of where that is in the airplane analogy, there's a reason why I do this work and not physics or aeronautics. So I went to go think about what actually gets that plane up in the sky and holds it there. And this was really compelling. That air generating an upward force called lift that overcomes the plane's weight and holds it in the sky. So, right, I think those relationships, that education piece, that is part of what is going to lift this up, overcome the weight, and sustain it, hold it in the sky, so we really do have that transformation.
All right. Well, thanks again for inviting me. I think the Birth to Three legislation is great. I wanted to talk a lot about what you were speaking about, that intersection between academia, public advocacy, and local government. And I think the Birth to Three for All DC is a great example of that, that intersection. My boss here, yeah. All right, my boss. Hello? All right. Yes, my boss, who was former mayor, former chairman of the council, when he came back, he wanted to address this infant and toddlers. It was his biggest concern. And when we had to craft that legislation, I'm a health person. I didn't have expertise in early childhood issues. And the availability of these coalitions like the Birth to Three Alliance or the Redstone Center, I mean, those are like critical in trying to figure out exactly how we craft this legislation. I have a master's in public health that I got from George Washington, but it doesn't make me a subject expert in school mental health or early childhood education. It just allows me to kind of speak the same language and understand the same concepts and convey that over to lay people who maybe don't have that same expertise. So I think it's really important to have those kind of intersections, those collaboratives. As council staff, I think our biggest charge at the local government is to find these subject matter expertise experts and take their solutions and bring it to everybody else. I think I'm pretty adamant in that the solutions to the problems that we have, city, nationwide, they're out there somewhere. Someone's already dedicated 5, 10 years, maybe even a career to working on these issues. And what we need to do is find those people and not recreate the wheel or create it the first time even. Just find what those people are doing that is successful and bring that to everybody else. Kind of turn those into solutions for the city. And that's pretty much what happened with that Birth to Three legislation. There was a lot of interventions in that bill that are already successful in Washington, like the Healthy Steps, Help Me Grow. All these things are healthy futures. All these things are successful in the district. And the only way you would know is speaking to the people on the ground that are actually doing that work. Absent that, you would just sit in your office, think of new ideas, or try to do the same thing that somebody else has already done. So again, organizations like the Redstone Center and the Birth to Three Collaborative, those are critical for us council staff to figure out exactly how we best serve the needs of the district. When I first started, I just graduated from GW, and we had left the school with, thousands of students just thinking about solutions, not only just solutions, but solutions to district problems. And when I left and I came to the council, it was like, where are all these people? How do we tap into that? No one else is thinking about how to solve these problems except for these students, academia, these organizations. So, it is always looked at as almost a massive waste when these people are thinking of these solutions and we don't have any way to tap into them. So when I got here, and honestly, my first foray into really reaching out to academia was with Dr. Dietz, Bill Dietz, and I reached out to him after I read an article that he wrote in Health Affairs about diabetes, and I was just, exactly how do we make those solutions on a local level? And of course, he was very open to talking to me. He was great. We had a great hour-long conversation, but it really turned me into the fact that really you can find these solutions and they're locally based, and it's really a matter of just reaching out and finding the people who are working on these issues. So really, I mean, I just want to wrap up and let people have questions. I know we were trying to get to Ben's Chili Bowl, but we need more of that. We need more people reaching out, letting us know what's going on. We have no way of knowing what the solutions are unless we hear from you guys. You guys have the solutions, and we want to hear them. And where we're at our best is when we're listening to academia or people who have already done these things and telling us how to solve our problems. And what we don't want to do is we really don't want to start thinking of how to do these things. Obviously we think, we obviously think, but we're not experts. We need you guys to engage in the process and continue to do that, and that will help us all move forward.
All right, so one of the things before you say a question, I know so much of what you've been talking about is activation of community. And so if you notice on that screen there, our latest tool that we produced is the Policy and Advocacy Guide. And so if you're really thinking about community activation, having the conversation around the pair of ACEs and many of the topics that we've discussed here, I really would encourage you to, these are free, they're downloadable. There's language skills in there with regard to how do we talk about many of the topics that we've talked about. Our teams can certainly testify to the fact that those things have been really helpful in us being in the advocacy space. So certainly use those tools. And if there's any groups that are interested in having perhaps a one-on-one workshop here in DC to really think about how do we activate our advocacy around our issues, we'd be more than happy to talk to you about that. So I want to go ahead, Olga, we've got like maybe 5 minutes for questions and closing remarks.
Just checking to see whether folks have, those of us parents have to pick up our kids or let the dog out, those kinds of things. So we just want to be respectful, but and this, of course, of your time. So I think Osa can stay around a little bit, but so if any of you want to walk Sarah out, if your question doesn't get answered right now, maybe you could do that and accompany her. But any pressing kinds of, anybody have a pressing question? Yeah. Okay.
Yolanda Hancock, community pediatrician and professor over at GW. My question sort of for both of, or all three of you, how does the DC Council reconcile the dichotomy between decisions that are made that impact our families in a negative way, such as relocation as a result of gentrification, or the closure of UMC's labor and delivery unit, where DC has the highest maternal mortality rates compared to any other state in the country, while simultaneously trying to create a plan for resiliency? How do you reconcile that?
I mean, that's a good question. I don't know how everyone reconciles this. I know that my office has been adamant about these same issues that you brought up. I mean, we've investigated these issues, particularly with the hospital, the healthcare system, and the sufficiency of it on the east end of the city. I think those are lockstep in what we're trying to do. We're trying to create, my boss, Councilmember Gray, is trying to create a comprehensive healthcare system for the East End where right now it doesn't exist. And in that is the hospital. And, it's his view, and obviously I share that with him, that we need a hospital on the East End. I think that we've all spoken with that same voice, including the mayor, who put it into her budget. I mean, they're going to continue to talk about when the funding is appropriate, when the hospital should start. But as far as our office, we don't have to reconcile. We believe that it's very important to have this healthcare system. It's also very important to have a continuum for 0 to 3.
My name is Tom Lotman. I run the Innovation Lab at Children Inc., which is part of the Cincinnati BCR group. I'm very impressed with the 0 to 3 Act that is being considered, particularly that it addresses healthcare, addresses early education, addresses parent supports. When I hear the early childhood education piece, what I'm not hearing is the universal approaches to social emotional learning in the early years. And particularly when we say social emotional learning, what is it that we want kids to learn? And particularly, I think research points that what's missing in social emotional learning is the alignment of SEL pre-K to grade 3 and beyond, that there isn't a skills begets skills approach. So what happens is that pre-K and kindergarten teachers are very adept at integrating social emotional learning during the day. When the child reaches first grade, there's so much concern about the achievement test, reading at third grade, that social emotional learning becomes 10 minutes on Friday. And so I'm curious whether there isn't room in what you're considering for that whole SEL alignment pre-K to grade 3.
I don't know if you have any comments. I'll make a few. It's one of the places that I'm really excited that I'm hoping we're going to continue to build between those of us who work very much squarely in the K-12 space and then those who work in the early childhood space. There's a little bit of overlap in that pre-K kind of kindergarten, but is that we do often see the gap, we see the sort of the chasm, and where kids then lose the gains they've made by third grade. And so, but they are very distinct systems. That doesn't mean we can't figure out how to take advantage of what's great about both of those systems in a way that we could build the capacity so that we're making a bridge across them. And I think we've begun some of those conversations very early on at a policy level. It's about thinking also who are some of the critical people who care about that conversation. Not to tout them again, but just, Bainham Family Foundation is one that says, wow, we've invested years and years and years in early childhood. Success is being ready for school. Now we're sending them to school and the context isn't supporting all of the advancements they made. Now we're going to do an initiative that's going to look at early elementary. It was fantastic, I think, built on a lot of the successes that they've already had with partners, and then saying, well, then who are the experts, who are the stakeholders who can help us think about how we continue that bridging. So I think there's a lot of those strands that we have to identify, everything from training, which is done very different in early childhood and teacher preparation programs, everything from sort of reimbursement of care and how that occurs, to education, to who the critical stakeholders are. I mean, there's a lot of things that I think we need to map across both systems and then start to really weave in where we're going to be able to make that come really closer together, because we have to be able to do that. Terrific. We're going to be able to look at that. I'll make sure to ask you so I have that link. But I think that's very critical. And I'll say one of the pieces that I think, again, an entity like a philanthropy or like a stakeholder that is really interested in sort of supporting some of the local advancements, they have particular roles that they can and should play so that they aren't over here supporting some kind of incubator project that isn't going to be linked to everything else that may be going on in the public sector or in other elements of the system, and bringing and identifying some of those partners and saying, great, you're willing to fund, seed some innovations, test out models, do demonstration projects, but then you weave into that has to be connected ultimately to what's going on in the others in the public sector, right? You mentioned this also, that they're wonderful conveners, because naturally we don't often always get to sit in rooms like this with such multidisciplinary players, right? And that's happened. We've had the luxury of having, in our task force. It's happened at the Policy Alliance. There's certainly pockets of that, but that's another role that philanthropy can play in saying, well, we then will support convenings that will support this, this aim or this goal that all the stakeholders have to see a part of themselves in. So those are just some things I wanted to make sure to mention also.
I would only add that the district has made some great progress in terms of collecting data through the early development inventory instrument. I always get the I confused between those two, and that social emotional piece is a core component of that. And I know there is a lot of work going on at the systems level in terms of thinking about how we're using that data and connecting that to kindergarten readiness. So just I think it's a great point that you raise and helps us further, think about this from these different angles.
So I love this robust conversation, and I'm going to pick up on what you said, Olga, about the power of convening. We are here today because of the philanthropic support from Doris Duke Charitable Foundation and Kresge Foundation. So I think that is an example of how we do leverage those private investments in order to bring these voices together. So I want to give our last panel a round of applause, a standing O for being here today. And Osa, thank you. You got here. So, but I also want to thank everyone who's been in attendance, especially those individuals who are here every day in Ward 7, Ward 8, Ambrose Lane, Council Member Trayon White, who actually represents this area, your Council Member Vincent Gray, they have been longtime champions of this community. I also want to thank all of our colleagues that are on the BCR team, national team, so Sarah Baldoff, Dr. Bill Dietz, where's Daniel? Everyone heard Daniel get some shout outs there. And Dr. Peterson, who is also doing the root causes projects for us, because I don't want you to think that this is the end. This is just the beginning. This is the first ever BCR Town Hall, but I don't see this as the end. I see this certainly as the beginning of a very long time relationship with the very important part of our city, and that we have a lot of work to do. So those of you who, this is your home, this is my home, this is the BCR team home, and so we're gonna roll up our sleeves and we gotta get it done. So thank you so much. It's a wrap. And you've got the email there. You know where to find me. Looking forward to working with you.